Once again, the theme for this year's conference is Strengthening Health Services in Africa through e-health and health informatics. For today, we'll be continuing with our symposiums, which will begin at 9:30 a.m. And our first symposium for the day is the role of e-health and health informatics in healthcare and health management information system. Our second symposium will be a special presentation by Dimaji Incorporated, a social enterprise based in Cambridge, Massachusetts, United States of America, that delivers open source software technology suitable for low resource setting and underserved communities. The company designs clinical interfaces, health information systems, and mobile technologies for patient-level disease management, clinical decision support, and health system monitoring. Our fourth symposium is titled Basic Models for the Deployment of e-health and Health Informatics in Health Systems. It will be taken by Michael Prude. The fifth symposium will be coming up by 3 p.m. and it's titled Road Mapping for the Development of e-health and Health Informatics. It will be taken by Dr. Olajide Adebola. So we'll leave you now to go through the readings for the day, and we'll be with you by 9:15 to commence our activities. Thank you.
You sure?
Please, do you have the CMD's numbers? Is national preparation. Good morning, ladies and gentlemen. We have effectively kicked off this program earlier on. We're happy to be on day 3, as is shown on the screen. We have the uncommon privilege of having the Chief Medical Director, University of Benin Teaching Hospital, Benin City, Nigeria, to address us this morning. For some technical reasons, this address could not be given yesterday, so we shall have the next few minutes with the Chief Medical Director addressing us. Professor Darlington Obaseki is our Chief Medical Director. CMD, sir, you have the floor.
Good morning, everybody. Good morning, distinguished guests. Professor Darlington Obaseki, I'm Chief Medical Director of the University of Benin Teaching Hospital. It's my pleasure and delight to welcome all of you to this conference that we've tagged MEHID-Africa, Mainstreaming Health, e-health and health informatics in development in Africa, of health services in Africa. We simply were thinking of how we can mainstream the deployment of ICT in achieving quality health care in different strata of the African society. The goal of MEHID is simply to development of African health sector through multi-sectoral deployment of e-health solutions. But to do this, we are very much aware that this is predicated on, first of all, strengthening the healthcare delivery system in Africa, providing quality healthcare to all our citizens. Quality in healthcare predicated on the 6 domains of quality, of efficiency, effectiveness, and patient-centeredness, and also, of course, having a safely delivered healthcare services. To do all this, we've realized that we need data. These services must be delivered in a way that use data to drive it. There must be data-driven intervention. And to get data, the ability to collate, and analyze this data, which we have done over the years in Africa manually. Obviously, in the modern age, that will no longer suffice. So we need to be able to do this in a digital format, and that's where e-health, and that's where this conference will come in very handy, that we need this data to drive our intervention. For example, we should want to create a living dashboard across our different hospitals that monitors on a live basis the different hospital vital statistics, mortality data, morbidity data, even non-vital statistics like bed states. How many patients are coming at any point in time? Which of the wards you have? What are the bed occupancy rates in your wards? And to do this, we felt that this would need to be discussed in a conference. We had envisaged this conference since last year, to be a more of a hands-on conference to showcase what we have done in UBTH thus far and use that as an opportunity to interact with our colleagues across the country and beyond to see what are the possibilities available. Unfortunately, the advent of COVID-19 outbreak have not allowed us to be able to do this the way we wanted to. But however, we delayed and delayed, hoping that we'll get over the COVID. However, we now decided to do it as a virtual, practically a virtual conference, and here we are now. There are a lot of opportunities for development of e-health solutions in healthcare in Africa. We have not leveraged enough on the widespread deployment of telecommunication technologies. Almost every individual in Africa now has one form of mobile phone or the other. And this mobile phone comes with very sophisticated technology. Some of them even have more technology than what we used to, the kind of computer technology that was used to land a man on the moon in the 60s. So we are holding very powerful tools that we feel can be leveraged on to help in healthcare interventions. And that is part of what we wanted to discuss, how we can leverage on the deployment of healthcare, of ICT to achieve better healthcare for our citizens. We are not oblivious of the challenges that this obtains. We are doing that in UBTH right now. Currently, not almost, all our consultation clinics are fully computerized end to end. Our general practice clinic, our consultant and patient department clinics, our antenatal clinic, they are all computerized. But we've witnessed live, real first time, the challenges that can come with this. The number one is power, electricity. You cannot deploy these things if you cannot guarantee power supply. You cannot computerize your services if your power is going to go for 10 minutes, because that have a lot of cascading effect downstream on the services you are offering. So ensuring that you have power, backup power, double backup power like we've done here, provide, apart from the public power supply, provide power alternatives of source through generator. But before then, have an inverter system that holds power for up to an hour before you power your generator. That is a major challenge here, and that we need to overcome across different centers in the country and beyond. Manpower challenge, to get the requisite trained manpower to be able to deploy these services, these computer services, there will be need for a lot of training. Our people right now, they are very, I would say, phone savvy. I don't want to use a computer. Almost everybody knows how to play with their phone, their mobile phones. But the actual business end of it, which is deploying simple Microsoft Word, for example, PowerPoint, Excel, we are still way behind. So we need to direct the attention of our staff on how to develop better along with the productive end, not just the social media end of technology that we are currently experiencing. So the team, which is training air services using e-health and health informatics, is very apt. And going forward, we are very hopeful that this is the first of many. Next year, hopefully, with the deployment of vaccines now, and we believe that the COVID situation would have abated, we are hoping to bring people down and see what is being done and how we can all share experiences going forward. So on that note, I want to welcome all of you. I attended yesterday's conference. I listened to Professor Temitope Longe, whose birthday was yesterday, and I particularly enjoyed his lecture, and Mrs. Pemu also enjoyed her lecture. So I want to welcome all of you and thank you for being part of this. Thank you so much.
Thank you very much, my Chief Medical Director. Professor Darlington Baseki has given a thematic address addressing the core issues about what MEHID-Africa is about, and also went into the theme itself, that is strengthening health services with the use of health informatics and e-health. He was particular about the advances that have been made in University of Benin Teaching Hospital with respect to e-health and health informatics. He emphasized strongly on the importance of data in driving decision making so that efficient and effective delivery of health services can become the routine. He emphasized how that University of Benin Hospital has advanced over the past few years, making e-health the norm in the hospital. Now we have fiber optics laid across the hospital, networking of different departments and different services in the hospital, and strengthening the capacity of the hospital to be able to deliver care. Coordinated use of data, informed real-time access to data in health service delivery is gradually becoming the order of the day in University of Benin Teaching Hospital. However, mentioned infrastructural challenges such as electricity to help to support and drive the good intention and the good services that have been rendered. Thank you very much, Chief Medical Director. In 2 minutes, we shall be going into the first symposium. So please, let's have a 2-minute break. Right, so thank you very much. We appreciate all our participants. Once again, you're welcome to today's program. We're still brooding through the very informative address of the Chief Medical Director, University of Benin Teaching Hospital. We recognize in our midst some very special guests who will not be able to introduce in full for now. But just to quickly mention, we have some resource persons even from yesterday's event that are here in our midst. But we want to go straight into the symposium. Our symposium for today, for this morning, is on the role of e-health and health informatics in healthcare and health management information system. We're starting with a lead presentation, followed by panel discussion, and then we shall have a session on comments, questions, and answers. Thereafter, we're going to have in our midst one of the panelists from the MEHID Incorporated will address us about the MEHID. That will come immediately after the symposium. So, ladies and gentlemen, I'd like to introduce to us Mohammed Idris. Mohammed Idris holds a bachelor's degree, a master's degree, and a doctorate degree. He is an instructor in the Department of Medicine, Morehouse School of Medicine, Georgia, Atlanta. He is a computational social scientist who has expertise in developing applications to support individual health. His work focuses on three main areas. He pioneered, well, on four major areas, sorry. He pioneered the practice of telemedicine. He incorporated the machine learning to better understanding patient-provider interactions, open source tools for analysis of high-frequency physiological data from wearables and mobile tools to enable community-based participatory research. Mohammed Idris has been working in different settings, but currently is an instructor, a medical instructor in School of Medicine. You recall that we introduced Professor Priscilla Pemo yesterday, has been from that same school. So we're talking of experts from the same community. Thank you very much, Mr. or Dr. Mohammed Idris. Can you please take the floor?
Fantastic. Thank you so much. I appreciate the wonderful introduction. By way of just one clarification, my work actually has not been in Nigeria. I believe that was from another colleague of mine's bio. So forgive me for having that included in there.
Sorry, that was my error, actually.
Okay, no.
Sorry about that. Thank you.
Not a problem, not a problem. Okay, so just wanted to clarify real quickly that you all are able to see my slides. The presentation is titled The Role of eHealth and Health Informatics in Healthcare and Health Management Information Systems. So again, thank you very much for the wonderful introduction and the opportunity to present some of my work. As the introduction mentioned, I am currently an instructor of medicine at the Morehouse School of Medicine in Atlanta, Georgia, where I work very closely with Dr. Priscilla Pemu, Dr. Elizabeth O'Feely, Mr. Michael Prude, and Chuka as well. In this presentation, there are a few things that I would like to go over. First off, I'd like to go over my background. I believe that my background, I think, provides an interesting perspective on this topic. And as you'll see, my background is rather eclectic, having had experience within the social sciences, having done work at a hedge fund early on in my career, having worked in the venture capital space, and ultimately finding myself as an instructor in medicine. Again, I have seen all the different aspects of building and maintaining eHealth applications from research through development. I then wanted to go into a kind of a brief history of eHealth and health informatics, again, now from the perspective of our experiences here in the United States, as a way of kind of telling a story broadly about kind of the knowledge that has been accrued in our understanding of both the infrastructure and the expertise needed in order to take advantage of these potentials, as well as their implications for healthcare from that collecting data and being able to do reproducible research that will ultimately allow us to kind of think more broadly about planning and managing healthcare at a higher level. And I think a lot of that for me, and as I'll get into further on in the presentation, really focuses on investments in people, processes, and infrastructure. A lot, as has been previously mentioned, progress has been made kind of within Nigeria and other similar contexts. But I really feel like, and I really would like for us to get across this idea of making the proper investments in infrastructure, processes, and people allows us to kind of do the necessary prescriptive, predictive, and prescriptive analytics. And in that, I will give a few examples of my work. And then from that, some stakeholder engagement, a really big takeaway that I think is often missed in these discussions, and then finally some takeaways. So I appreciate that opportunity, and I look forward to feedback towards the end of the presentation. So in terms of my background, my family is actually from Eritrea, just outside of Ethiopia. I was born and raised in California, studied economics at the University of Washington. After that, did a short stint in the hedge fund space at a rather large financial institution called BlackRock in the alternative space. I then went on to do a master's and a PhD in social data analytics at Penn State, where a fourth of our training was in graduate level statistics, a fourth in computer science, a fourth in visual analytics, which you could think of as any field where you have to use data visualizations as a way of communicating often technical information to key decision makers, healthcare being a good example of that, but applying all of that within a very specific domain. And of course, I focus mainly on the social sciences and socially generated data. But again, there are a lot of implications of that within the realm of biomedical and e-health sciences. I then went on to do a fellowship at Harvard, a pre-doctoral fellowship in political economics and data science, where, on one hand, we were looking at kind of countries within the Middle East, after having going through some kind of rather big seismic shifts in terms of their kind of political systems. We're looking to kind of put in place the proper infrastructure to take advantage of providing public services, including healthcare, and then also building data science tools for researchers at the medical school. I then went on and did a postdoc in data science and preventative health in Concordia University in Montreal. And also at the time founded a technology company, and I did a TED talk on this idea of how is it that we can leverage technology to kind of help people help themselves. And as you can imagine, a lot of that relates to e-health and the ability for folks to leverage technology to help provide services at scale. I also have experience as a principal data scientist actually building tools for hospital systems at an organization called TerraCrunch, and did a venture capital fellowship at a firm called Cabria, where we invest in early stage, including healthcare tech startups in emerging markets. And then most recently, before joining Morehouse, where my research focuses on, again, e-health broadly, but also leveraging machine learning to better understand patient-provider interactions, did some of that work in environmental medicine and public health. So again, I think, again, my experience is wide-ranging, looking at it from the perspective of research, from the perspective of industry, from the perspective of investments in capital, but ultimately coming back to it from the perspective of being able to, as the previous speaker had mentioned, taking advantage of advancements in data and infrastructure and technology to be able to really take advantage of the potential for e-health. And so in terms of a brief history, one of the things that I like to talk about and emphasize is that in the same way that we talk about machine learning as being kind of this cutting edge new set of methods, a lot of that work was actually done 10, 20, 30, 40, up to 50 years ago. And when we think about e-health broadly, we can actually tie that to between the late 1940s and the late 1960s, the precursors of modern health informatics and health information management systems being born. There was early work by Dr. Gustav Wagner in Germany in 1949 to set up the Society for Medical Documentation, Computer Science, and Statistics, which was the world's first professional organization around informatics, and really, in many ways, paved the way for informatics to become an integral part of the healthcare industry across the world, Europe and the United States as well. In the 50s, early 50s, we have the first kind of example of a computer being used. It was called McBee, a manual punch card presentation given at the American Society for Clinical Pathology. In the late 1950s, a very influential paper called Reasoning Foundations of Medical Diagnosis, which made the first case, again, before the technology really existed, for computers to be integrated into the healthcare field. to both automate work, but then also in a way of reducing errors. And then again, we've seen kind of the first ever use of an EMR in the United States in a hospital in Utah, and the development of the first programming language, which was specifically designed to make it more easy to create medical databases and integrate them into healthcare. Again, all of this done through the late 1940s and the 1960s. Now we could jump into the 1980s, where we saw the first kind of set of software kind of being implemented within the sector. Patient scheduling, there was a software called Cadence that was released in the 1980s. We also saw the first quite significant large, and this will be a recurring theme as was mentioned from the previous speaker, of kind of investments from government into kind of the development of these healthcare systems. This initial investment in the 1980s was done to develop healthcare systems for all military health centers, and is still used today. We also saw the launch of professional associations here at the American Medical Informatics Association to educate professionals in information systems and standards. Again, the idea here being that investments in individuals and their understanding of the systems and the processes and the importance has really played has been an important role since the beginning of kind of the birth of this work. In the 1990s, with the rise of desktop software, we saw the first Windows-based EHR system called Epic Care. But then also, and honestly, since then, a growing focus on interoperability, where these first healthcare systems were designed within organizations, but of course, data exchange is a significant part of the development of these industries, and we can actually trace a lot of that work back to the establishment of an organization in the late 1990s called Integrating the Healthcare Enterprise, which sought to develop frameworks and specifications for healthcare information exchange. And as I mentioned, we've since seen kind of a lot of advancements in the field of interoperability, and even startups, as I'll talk about in a second, who have actually made it a business to provide data on interoperability between healthcare products and provider EHRs as a service. But it really, in the United States at the least, it wasn't until 2004 with the creation of the Office of the National Coordinator for Health Information Technology that we really saw kind of a nationally coordinated effort to bringing these technologies to bear. And just to provide some context, prior to 2008 in the United States, only about 10% of hospitals adopted electronic health record software. This is not very long ago. And the reality was that it was too expensive for providers to move from a paper-based system without any sort of proper financial incentive. And so, in 2009, as part of the stimulus package, there was the HITECH Act. This is the Health Information Technology for Economic and Clinical Health Act, which was put forth by the Obama administration. As I mentioned, before this act, the cost of digitization was prohibitively expensive. And these incentives really encourage hospitals and other healthcare providers to make that change, to go digital, not just in terms of digitizing their services, but then also in terms of investing in the proper infrastructure, processes, and in people as well. And so what we've seen since that was, from a 3.2% adoption of EHRs in 2008, to by 2017, 86% of office-based physicians having adopted EHRs and 96% of non-federal acute care hospitals implementing certified healthcare IT. So again, it really, while a lot of the precursors were there, it wasn't until there was a nationally coordinated effort, along with the proper financial incentives, the development and infrastructure standards, so on and so forth, that really led to kind of this proliferation of e-health technologies that we see today. And that includes a variety of things. I myself have used wearable technology in some of my research during my first postdoc in Concordia in Montreal. This includes everything from being able to monitor heart rate variability to sleep to a lot of other physiological signals that, of course, are useful and an important part of understanding somebody's health. We have seen kind of the massive push towards the use of technologies, including tablets, at various points of care, and something like, as of 2013, 3/4 of physicians are using some sort of technology or tablet to maintain health records. And a lot of this has really powered, kind of allowed us to take advantage of the opportunity to leverage machine learning, where if we are collecting the appropriate training data and we have easy access to it in the form of electronic health records, we are able to start thinking of interesting questions, designing interventions, building models, and again, really taking advantage of the promise of machine learning by leveraging training data from these electronic health records. And really the story here is one of a variety of different stakeholders coming together. These include patients, providers, folks within policy, and even small and medium enterprises, what we would often refer to as startups, as coming together in order to create an ecosystem, an interconnected ecosystem, which is mutually beneficial for all stakeholders involved. And so you could imagine here we have an illustration of what this ecosystem might look like. We have everything from diagnostic image centers to hospitals, pharmacies, physicians, employers, folks within the insurance space, medical suppliers, academic medical centers, public health surveillance. There are a variety of different stakeholders who, when working together, actually can, again, really take advantage of the opportunities. So you could imagine a patient showing up at some ER, a physician looking at their medical history by looking at their EHR, perhaps ordering some tests in order to do some diagnostics around their situation, prescribing some medication, being able to refer them to a specialist, all while understanding and documenting their social determinants of health and providing them access to services, again, being done in an interconnected system. And really what is required from all of these stakeholders is a level of interaction, of collaboration, opportunities to document and collect the appropriate data, opportunities to test hypotheses using this data. And again, as I mentioned, this is not just providers and patients and those within government policies putting in place standards and investing in infrastructure. This is also startups who in many ways are coming up with innovations that will allow, for example, physicians to easily access cutting edge clinical information, which might be behind a paywall for academic publishers. We've seen innovations around pharmacies and being able to interact with your pharmacist over text and have your prescriptions delivered to you. There's a lot of interesting work being done in the healthcare transparency space, where you have kind of platforms as a service that will allow employers and employees to be able to identify low-cost procedures and alternatives. Platforms for crowdsourcing these tools, where you might have a simple procedure cost 10 times as much down the street, and we've seen some instances of that. A lot of work can easily be leveraged, and there are kind of, value to be added in terms of clinicians themselves being able to do much more with their limited capacity, i.e. leveraging machine learning to classify x-rays, whatever it might be. There really is an important part that each of these stakeholders play in terms of creating and maintaining this ecosystem. And that's really, in my mind, the biggest takeaway from kind of what's been done in the past. And so, as I mentioned, really what it comes down to in terms of what we can learn in terms of investments in infrastructure and experts, our delivery of healthcare leading to data, and then from that planning and so on and so forth, is really taking the time to make the proper investments in people, processes, and infrastructure. And where does that start? Of course, it starts at the top, as I'm sure multiple people have mentioned, governance. And now, in order to take advantage of the societal benefits of e-health, a shared vision is needed, and that is often driven from the top. And by better here, in terms of better, health services, we mean both here in terms of costs and outcomes. We need to have a way of understanding the various points where folks are interacting with the healthcare system, to better understand their conditions, to be able to better understand and put in place proper interventions, and then from that being able to tie to better outcomes for a more values-based approach to care. And I think, again, from a governance point of view, this shared commitment needs to be bipartisan, and it's needed to facilitate collaboration, as we mentioned, between various stakeholders and to incentivize in these investments in people, processes, and in infrastructure. And I think a good example of a strong political commitment at a national policy level can actually be seen quite across Europe, where we have many countries, for example, Finland has the National Institute for Health and Welfare, which is really meant to establish kind of a permanent administrative support to incorporate e-health infrastructure, those infrastructure requirements. And as we're talking about that, it's important to constantly remind ourselves, and I love that it was already brought up a few times, this idea of kind of fiber optics and that infrastructure currently being put in place, is to remember that all of these e-health technologies rely on some sort of low latency connectivity to work. And the idea here is that information needs to move quickly and safely from a variety of different devices, whether they be wearables, mobile health apps, and this data needs to be stored and transferred securely to electronic health records, which is kind of like the holy grail for a lot of these systems to be able to function properly. These data could look a variety of different ways. So, for example, complex images, for example, X-rays need to be transmitted, stored, easily accessed to make diagnoses. We mentioned earlier, this idea of high-speed fiber optic networks will allow, or really ensures that institutions, teaching hospitals, and other kind of network organizations to be able to transmit healthcare data efficiently and securely. And again, this is what it does, is create more options for communication between healthcare providers and patients. Again, one of the things that I've tried to think a lot about is how is it best that we can capture a lot of these interactions to better understand patient-provider interactions and design better experiences. But going back to this idea of connectivity, it really makes it possible for patients to access consultations. An example here, and we'll talk about in a second, is telehealth, and enables collaboration between treatment teams through a unified communications, real-time monitoring through wearables. The idea is not just for the person wearing the wearable to have that information, but for that data to be immediately accessible to healthcare providers. And fiber optics can provide a secure data transmission for that. Another added benefit, of course, of these infrastructure investments is that around security, which, as I'm sure we know, is becoming a bigger and bigger, is becoming top of mind for patients themselves. And so again, fiber optics is, more difficult to hack than copper cables. Fiber optics are also impervious to water, electrical interference, and other extreme pressures, where again, what you really need is the stable infrastructure to be able to both get online, but also to maintain these systems. But then ultimately, while there might be governance to define objectives, put in place standards, and the infrastructure, it really is software that's ultimately going to be driving a lot of this. As we mentioned, electronic healthcare record systems are the cornerstone for that, and a variety of standards for interoperability have been created. One of the things that I found to be really interesting in both my understanding, but also looking at the development of the space, is how innovative startups tend to be in terms of making it easier for larger institutions to be able to take advantage. So, for example, I mentioned there is a startup in the United States called Redox, I believe is its name, where they've essentially created data interoperability between healthcare products and provider EHRs as a service. So if you could think of any two platforms, e-health platforms, which are commonly used in the United States, they've likely developed some sort of integration that securely allows folks and very easily and through very well-documented APIs allows folks to essentially exchange information between a variety of these different digital health and e-health applications. Moving on from there, the governance infrastructure, the software, of course, the next piece is then the applications. We could talk about digital identity, the requirement of any one individual to uniquely identify themselves in a privacy protected way across various points of connection to the healthcare system. The possibility of telehealth to make it more accessible for folks in rural areas to access medical attention. This idea of e-prescription, the ability to kind of at any point of care, being able to prescribe information, being able to share that information. One area where I believe is taking, where I've seen quite a bit of uptick, where I do believe there is quite a bit of untapped potential, is from the ground, from day one, starting to think more deeply about how to integrate social determinants of health screening as well as referrals within these e-health solutions. And there are a few good examples of that being built into existing EHRs. But the idea here, again, is to provide any one individual kind of holistic access and an inclusive experience in their interaction with the healthcare system. And again, that starts with governance, infrastructure is required, software is what's enabling, and then finally, the applications. The idea here, though, is if we have these pieces in place, then only then we'll be in a good position to be able to leverage existing data to make data-informed decisions, both in terms of practice, clinical practice, but also in terms of research as well. And so here, again, assuming that the proper infrastructure and the applications are in place, there are a variety of best practices in terms of research and data management that I feel are kind of important to both understand, but also to implement in terms of being able to take advantage of the possibility of e-health and a lot of these health information management systems for healthcare and research and development. And one of those really focuses on this idea of reproducibility. So it's this idea of having everything documented, both in terms of where the data came and how it was analyzed, to be able to generate research which can be reproduced or in some cases replicated. And what we've seen, and this is just going to, it really picked up, I would say 4 or 5 years ago, and now it's becoming standard, is this idea of a variety of funding agencies and journal publishers requiring sharing data that will allow others to people to reproduce results that are often reported in our research. And facilitating reproducibility of published works here is probably the most important objective of research data management, and helps improve research results over time. And some of the work that I did while I was at Harvard really aimed to put in place a very kind of low cost, easy access data repository called Dataverse, that really implements what we call FAIR data principles, which refers to findable, accessible, interoperable, and reusable data. And the idea here is not that just everything's accessible, findable, easily usable by humans, but also for machines as well. And these principles, if you're not familiar with them, have really become quite popular and widely used within the data management, research and data management community. And an increasing number of data repositories are aligned and compliant with these data principles. And so it's this idea of, beyond having the governance, infrastructure, the software, and the data being collected through a variety of different applications, it's having the infrastructure to be able to share that data, make it more easy for people to access that data for the purposes of research, I think is part and parcel really significant throughout thinking about the use of e-health more broadly. And one of the things that really, I think, is the reoccurring theme in a lot of what we've been talking about, and I've heard it touched upon in a few of these presentations, is this idea that it's not just about the technology, it's also about the people. And it really comes down to training, and then some more training. I like to think of this kind of transformation towards e-health in the same way that I think about digital transformation more broadly. And that does not necessarily simply focus on digitizing existing services, but focuses more so on leveraging technology to innovate. And the way I like to think about it is, in this case, digital is more synonymous with the pace of change. And the reality is that the pace of change will only accelerate. So really thinking through what are the foundational things that need to be put in place to be able to take advantage of both the advances that are here, but those are to come, I think is really important. And beyond, again, just having an IT strategy in place, it really is putting in place a sort of kind of going through this journey of a strategic, planned kind of organizational capacity shift or change, and really empowering folks with both the kind of the resources, but then also the knowledge of how to leverage new methods, new technologies, to really be kind of responsive first and foremost to the needs of patients, but ultimately thinking about developing a culture of innovation that I think is really important to be able to both kind of build, maintain, but then also continue to sustain these sorts of potential with eHealth. And so what does that look like? We could think of this, and I'll give a quick example, but across 4 different areas where if we are able to have the appropriate infrastructure, practices, and training in place, we can look at very basic things like how many patients went to a hospital within the last week, really this idea of these descriptive analysis. We can move that up to diagnostic analytics. So why did patients go to the hospital? Again, looking to dig deeper into their health record, have previous, notes or previous notes there that might provide some additional context, so on and so forth. But the idea being that we should ultimately find ourselves in a place where we could be a little bit more predictive, i.e., what should the next week actually look like to move to this place of being as prescriptive as possible. This idea of creating these, as I'll show you in a second, these very kind of unique and data-driven and very patient-specific plans of care that we could then use to kind of provide better services more broadly. And what might that look like? Here I wanted to give really quickly, and I realize, I apologize, I'm going a little bit longer than I anticipated, but I do want to give a quick example of what that looked like in one of the projects that I worked on, where we built a piece of software that allowed an outpatient physical therapy, a therapy unit of a hospital system, being able to identify, create patient-specific plans of care, and then from that automate the scheduling of resources, including nurses. And so at a very descriptive level, there was information coming out of the hospital about how many patients would require some form of therapy without being very specific. So this was often based off of what procedures were being done, so on and so forth. But what that required is a little bit more digging into thinking more specifically about, what the unique patient characteristics were, what surgeries they did, what was the outcome of that, and whether they would need different types of therapy, whether that be physical therapy or speech therapy. Again, a lot of this information existed in different systems, but again, provided a holistic picture of what is needed from a diagnostic point of view. But ultimately, what we wanted to do is build a model that will allow folks to allow practitioners here to be able to predict how much physical therapy or speech therapy is needed to improve rehabilitation. And again, we had historical data on that. Putting all of this together, being able to build actually a custom piece of software that allowed us to ingest information from a variety of patients, from a variety of different resources, to train a model that will allow us to predict how much therapy is needed to improve rehabilitation outcomes. We were then able to generate patient-specific plans of care, which was patient A needs X amount of minutes in physical therapy, Y amount of minutes in speech therapy. We would also have an idea of what resources were available. We would be able to implement within our scheduling system a variety of constraints, including, for example, any one patient not having more than 120 minutes of therapy or in a row, ideally trying to constrain who their therapist was, so they have continuity in terms of care, so on and so forth, were all things that we were able to incorporate. And so I think that provides a really good example of going all the way from being able to leverage data for descriptive analysis, but the goal being to train a model, to build diagnostic tools that will allow us to make more prescriptive database decisions. And this really brings me down to, and this is one of the bigger takeaways that I'd like to emphasize in this talk, is this idea of stakeholder engagement and e-health literacy more broadly. And if we look at a lot of the work being done in the United States around e-health, around in particular mobile health interventions, it's pretty striking and pretty obvious that we have higher rates of attrition in underserved communities broadly. And if you look a little bit deeper, this ranges all the way from not having understanding the perceived value, limited understanding of digital and health literacy, so barriers there, and just generally a lack of understanding of the relevance or the opportunities or the benefits of such technological innovations. And what we've seen is that where we have unequal adoption of e-health innovations, and this is one of the points that I'd like to emphasize for our talk here, is that really adoption matters, because if we're simply talking about the potential benefits of e-health, but those benefits are not being realized by those who are underserved, we're actually going to find ourselves in a position of exacerbated health disparities. And this is something that we're constantly working at Morehouse, where we've seen kind of this unequal adoption. But what we've really noticed is that if you engage communities, those who are often underserved early on, in terms of understanding what are their unique requirements, what are their unique problems, so on and so forth, you can actually design better interventions and better technologies that are more likely to be used, can have higher rates of adherence, and then ultimately lead to better care, which is at the end of the day, or equitable care, which is really the promise of e-health broadly. In terms of takeaways, and I'll end here, number one, top of mind is the idea of collaboration amongst the many stakeholders. What's needed is a shared vision and a commitment to short and long-term goals. This includes, again, both an agreement in terms of where we want to get to, why we want to get there, an agreement in that there are going to be significant investments needed to be made, and innovation mindset adopted across various levels. But again, this collaboration and this integration between the various stakeholders is really important. I think the second piece is really thinking more specifically about patients and providers who in many ways need support to actively participate in e-health projects. And those must also be relevant to their challenges and needs. And so, for example, I just spoke about patients being asked to adopt technologies that they weren't necessarily consulted in the development of, providers needing an incentive to overcome some of the economic costs associated towards moving towards a more kind of digitally technology-enabled healthcare system. A lot of training is going to be needed, acknowledging that the support is needed, and e-health projects and strategies more broadly should be what's the word I'm looking for? Responsive to the needs and the challenges of patient providers, I think is fundamental here. I think a third thing, it's been pretty obvious based off of my reading and following of the development in more developed kind of in more mature markets, I should say, that there really is an interesting public-private approach that is going to be essential for being able to realize this potential. Because as we said early on, there are pretty significant investments needed in infrastructure and standards, so on and so forth. But it really has been some of the startups and entrepreneurs and the ecosystem of small and medium enterprises that I think really has kind of is allowing us to take kind of that step further, both in terms of building more inclusive and accessible technologies, but then also being able to scale to kind of the potential of kind of nationwide systems, so on and so forth. Which brings me to the last piece, I think it's really important to think instead of beyond thinking about these as kind of disparate kind of groups who have their own unique interests, to really thinking about communities more broadly. These are communities that can be leveraged and need to be involved, as we mentioned, in every aspect of the development of e-health policy, infrastructure projects, so on and so forth. And I think there really is kind of a missing opportunity. There is a missed opportunity, at least here in the United States, for being able to leverage existing communities, the trust that they've built, the networks that they've built, and really thinking about how best to leverage technology to help folks who are already doing interesting work, enabling them with the technology to kind of scale, to define and scale these efforts, I think is really a big takeaway as well. And so with that, I'll end. Here's my email address. Please feel free to reach out at any point. And I guess I'll end it there. Thank you so much.
Oh, great. Thank you very, very, very much. That's a very, very comprehensive presentation. I think all participants will agree on that. I'd like to also let those of us online realize that there are many more people out there at different viewing centers in and beyond the University of Benin and University of Benin Teaching Hospital who are participating actively in this conference. I would want to encourage that we all pay attention to the lessons being shared. Dr. Mohammed Idris has done great justice to the topic, paying plenty of attention to the issues of data and the technology that drives the data, the health ecosystem being a basis on which to develop an ecosystem for the technology that drives it. This is extremely important and means that we need to be much more fundamental in our approach. I'm not surprised that Dr. Mohammed Idris is able to go this far, given his background. Now we can appreciate why he gave us that background. A social scientist going into technology, going into statistics, and is able to bring together all of these in one piece. That's the kind of thing we need, the kind of drive we need to help us to guide our thinking in establishing or deploying e-health and health informatics. It's not just about the devices that people bring or they want to sell to communities and countries. It's about what fundamentals exist in those places, what needs they are, what systems have been developed or are being developed, the nature of the ecosystem, and how that ecosystem is expected to function, the investment environment within the ecosystem, and other inputs, just as Mohammed has said. So that was quite a thorough one. I found particularly interesting one aspect of the presentation that talked about fair data principles. And those fair principles are things we need to adopt. On one hand, we want to ensure that there is adequate protection for owners of data. There is also ethics in the management of the data, and that we do not have undue portability of data. There are regulations on this, even in Nigeria, but developing the systems to mature sufficiently for everyday application and to drive these processes through electronic means is something we're yet to adopt to a large extent. So once again, Dr. Mohammed Idris, we thank you very, very much for your very educative lecture. It's an eye-opener and it challenges us to do much more. So right away, we go into the panel discussion. We have a short time left and we encourage our participants to please feel free to send in their questions so that we can look at them. So I'll introduce the members of the panel right away. First, first to introduce Dr. Sonny Eyaru, who was with us yesterday. He participated and was actively engaged, following through the discussions and presentations. Dr. Sonny Eyaru is a medical doctor and a pharmacologist, but is probably far better known in the field of health informatics. He developed a very powerful technology widely used in different hospitals in Nigeria. Dr. Sonny Eyaru is sometimes even called by the technology he developed, Rapid Medics. Rapid Medics software is used in University of Benin Teaching Hospital and other health facilities. His software has been invaluable in electronic management of health facility records. So, Dr. Sonny Eyaru, you're welcome.
Thank you very much.
Yeah. We also have here on the panel we have on the same panel Mr. Efosa Igodan. Efosa Igodan is a lecturer in the Department of Computer Science, University of Benin. He started his career in computer science practice as a system analyst. He was, in fact, in the University of Benin Teaching Hospital for some years, where he was exposed to trainings and conferences in telemedicine and mHealth. Efosa Igodan is now a lecturer, where he then passes on this knowledge to students and is into research. His research interests have also addressed health informatics. He works closely with his colleagues and is currently pursuing his PhD program in computer science. We have another member of the panel who's from the MEHID Incorporated. As we showed in the program, the MEHID Incorporated is a social enterprise based in Cambridge, Massachusetts, USA, that delivers open source software technology suitable for low resource settings and underserved communities. The company designs clinical interfaces, health information systems, and mobile technologies for patient-level disease management, clinical decision support, and health system monitoring. That's where Carlos works. Carlos Sherina is Senior Director, Program Design with special focus on Africa. He's the Director of Partnerships Southern and East Africa. He's also the Head of Partnerships Southern Africa. He is Partnership Development Manager for the MEHID, and carries on with so many other responsibilities within that organization. He has a broad background that have to do with urban structures, urban designs, sustainable development, sustainable management service, and so on and so forth. He has experience in business and deploys all of these into what he does in the MEHID. Carlos Irina, you're welcome.
Thank you very much, everyone. It's a pleasure to be here.
Yeah. All right. So now that we have a very, very robust panel, we can only expect great things to come. Can I please ask Carlos? I think I should start with Carlos. What are your insights about what Mohammed Idris just shared with us with respect to driving healthcare and health management information system?
Yeah, thank you so much. And thank you so much to Dr. Idris. I think it was a great presentation, and it really resonated a lot with what, the MEHID as a social organization, it's trying to drive in terms of our mHealth solution for health systems in general, but also through a lot of different programmatic areas that goes, from agricultural extension workers, governance, education, et cetera, because one thing is that we've seen that definitely with a health focus, digital technology can do a lot, but this can also be replicated to other programmatic areas. And so I think one of the pieces that really resonated with me and our sort of ethos as an organization is the piece around what Dr. Idris mentioned in terms of it's not only about the software/hardware that one can select or deploy on a specific settings for specific requirements, but it is mainly and most of the times most important to take into consideration the end user as well as the capacity development transition to ownership and sustainability. So in our experience, what we've seen is that the technology can be very powerful by itself. The hardware can be very powerful by itself. But when it is still considered as a side intervention or silo type of piece for the entire program, the impact is not as amplified as if we take a sort of bottom-up approach where we focus on the end user. What are their needs? What are the requirements? What is it that we're really trying to solve with the technology? Again, the software and the hardware. And once we are clear on that, then whatever we're able to build or to develop really has the desired impact that we want. In most cases, we've seen technologies being designed far away from where the actual problem is. And so one of the things that we pride ourselves at the MEHID is that we follow this specific approach that we called our designing under the mango tree type of approach, which basically just means going into the field and talking to all the relevant stakeholders, whether there's going to be, I'm not showing any slides at the moment. I think the presentation around the MEHID will go afterwards, and then I'll be able to share the,
That's right.
images.
Yeah, Carlos, you're going to do your presentation later. We just wanted your insights on what Dr. Idris presented.
Yeah, exactly. So again, just for us, that designing with the end user and making sure that we're taking into consideration those pain points, it's what resonated with me the most, because I think it's important for us to center ourselves in what is the issues that we're trying to solve so that we get closer at solving them. So not designing and creating systems from afar, but really engaging with the end users that are the ones that are going to be using the system to understand what the challenges are. Sometimes it's not necessarily about just, digitizing paperwork forms into a digital form. If we are digitizing a robust, cumbersome type of intervention or data collection piece, it will just be the same, but in a digital form. So basically moving from a paper-based, excuse the terminology, but trash into a digital trash, if that makes sense. So anyways, this is one of the pieces that resonated with me the most from the presentation. And I think it's very important for us to consider that when we are thinking of implementing any type of digital solution or intervention in any of our programs. Hopefully that answer and spike some interest on the panels. Over.
Right. Thank you very much, Carlos. That was fine, and I'm happy you were able to bring into perspective what the different possibilities. But I may highlight here that even if an institution or a health system simply digitizes its work, just transforms from paper to digital technology, that's still some value, don't you think? Especially when you look at the sheer volume of paper used and the implications for the environment. In other words, From the point of generation of the paper, that means we can preserve more trees. To the point of managing waste from the paper, we can better protect the environment. Don't you see technology as being digital technology or e-health as helping to protect the environment in that wise?
Certainly. I think that there's benefits that are already, embedded into transitioning from a paper-based form to a digital form. Again, it goes from environmental pieces, the waste that gets overall, as well as reducing error, faster aggregation of the data or reporting of the data. Definitely, that's definitely a sort of given. I guess my point is that we have to be careful on, making sure that those systems do not further overburn whoever the user might be. So it does require a little bit of change management in terms of going from one a paper-based system to a digital system. So, besides the given sort of benefits, we really want to look further to make sure that these systems are really creating that impact that we give. So, moving away from what is already a given, but making sure that we're taking the full advantage of the benefits that mHealth or digital solutions can bring. And again, that's in a way that, minimizing the amount of questions that are asked in a form, because maybe one question can be related to the different forms. So that type of design to make sure that we're not only digitizing the paper-based form, but we're making it more efficient. I think it was my point, the point that I was making. But certainly, I believe that just going already from a paper-based to a digital will bring its benefits by itself.
All right, thank you very, very much, Carlos. So the point is that it's a far more comprehensive consideration when one has to deploy electronic technology in health informatics. It's not just about digitizing for the fashion of it. I got the point very well. Thank you very much. Can we go to Sonny Eyaro, Dr. Sonny Eyaro? You have hands-on experience in bringing about the kind of transformation that Mohammed Idris talked about. Would you like to talk from your experience? Let us know what you think is possible going forward in Nigeria. What can we begin to make to happen?
Well, thank you very much for the privilege to contribute to this session. Basically, from my experience about informatics and automation of hospital system, the basic thing I want to contribute is that it's important to know that we need solutions that are customized to simulate the existing manual practice in a hospital. That is to say, if you look at what we had on ground in UBTH before Rapid Medicine came on board, you are paper-based, case note-based. For example, the structure of the antenatal records is different from the structure of the other traditional clinics, like the consultant outpatient in medical medicine and all that. So when building an app, my experience is that you have to customize it to make the data capture, to make the interface similar to what you have been capturing before the digital system came on board. If you build something that is not in consonance with the actual practice of the users, you are going to have a lot of conflict with them migrating from paper-based to digital. So you have to build what we call customized system that will make the transition seamless, that will make them just see themselves as doing what they have been doing before, but this time around on a digital platform. When you do that, you won't have problem with migration. Then apart from that aspect, you also have to make sure you have robust infrastructure. Basically, a hospital must have infrastructure that has to do with the infrastructure on which the technology will run. For example, you will need to have servers, data centers, which is the center or core of the technology. And then you need to have network that reaches out to all corners of the hospital. And then you need to have workstations like phones, tablets, computers, and all that, from which the end user can log in and do their transaction. So apart from investing in the technology to be robust and customized to suit the existing practice in the hospital, you also need to invest in infrastructure so that the infrastructure can drive the technology. And then you also need to invest in people to train them to be able to know how to use the technology. This is exactly a summary of one of the lines of Mohammed Idris in his presentation. He said you must invest in people, you must invest in processes, you must invest in infrastructure. And then the policy makers, the government and the hospital management also have to be carried along so that funding can flow to get all these things accomplishable. So that is my hands-on experience. If you just try to acquire a package that did not have your input as an end user in how it is built, in how it is run, you are going to have conflicts. So that's why customized solutions that takes the end user into consideration, that takes your input, so that it will lead to modification of the app until it suits the flow pattern of your transaction. That is how you win in customizing and in digitalizing the hospital. Then most importantly, power is an issue. If there is no power, then you can't even become automated. And that's why University of Benin Teaching Hospital has done very well in that respect, because apart from the fact that they have standby generators, they also have the inverter system that can stand in the gap when there's power outage, so that the technology does not go down. If it goes down, it's going to have a spiral effect on the hospital. There's going to be a lot of downtime, and waiting time of patients will be horrible. And if that happens often, it will lead to abandonment by the end user. They will just go ahead and grab the case note and start using it again. So that is one of the areas where University of Benin Hospital has done very well. They've addressed the major issues of power. They've addressed the major issue of infrastructure. You have robust fiber optic network running. You have good workstations that have capacity. You have data centers. So that's why UBTH is succeeding. Some people start this technology in their hospitals, but they're not able to sustain it because they don't address this basic nitty-gritty that I'm talking about. So that's how that's my hands-on experience in dealing with the hospitals that I've been able to deal with nationwide, and I'm able to sustain and support them. Over. Thank you.
Thank you very much, Dr. Sonny Eyaru. That's from real hands-on experience. It's an expression of your experience in line with Dr. Idris's lecture. We want to quickly address something here about building everyday technology to match these needs, and talking about the issue of training. I've often looked at e-learning as a platform on which to build all forms of e-technology, whether it's e-health or e-commerce or whatever else. Mr. Igoda Efosa, lecturer, Department of Computer Science, University of Benin. Where do you think training comes here? Must it be a university degree? What kind of training do you think we need that will support development of appropriate technology, that is technology that is appropriate for our environment in Africa? What are your thoughts on this? Oh, I guess we lost. Okay. Please unmute your mic.
Okay. Thank you very much. Can you hear me now?
Yes, we can.
Yes. Thank you very much for the question. I think it's very key to start from the primary level. It can begin from anywhere, whether at the university level or the secondary level. But to actually indoctrinate this whole concept about e-learning and health informatics, it has to begin from the primary level. Whatever it is, the government, it takes the government to form to put the curriculum in order. Whatever the content may be depends on the level. Now, if it begins from the primary level, of course, the content will be small. Then it goes up to the secondary level, then at the university level, because now we're talking, ever since the pandemic, the COVID-19 pandemic, the world now has embraced electronic gadgets, information technology, and the likes. So we're now using modern tools, modern technology to solve our problems, to meet our everyday needs. So if it begins from the secondary level, the university level, then of course the curriculum will be very much robust. Training is very key because one of the components of e-learning and health informatics is computer science. Apart from computer science, we have information science, and we also have health science and cognitive science. So begins from the university level. The university players. Hello, can you hear me? Hello?
Yes, we can. Yes, we can. Go on.
Thank you very much. So as I was saying, if it begins from the university level, then of course the curriculum, the content must be very robust, because one of the companies, health informatics, okay, apart from telemedicine and other means we can use e-learning, electronic health and health informatics, is computer science, information science, health science, cognitive science. So if we take computer science, for instance, there are a lot of things we can learn. We can train our students on that has to do with health informatics, electronic health, as regards what it takes to be an expert, what it takes to maintain these infrastructures, what it takes to embrace this new technology that the world is faced with. The content, of course, as I said, must be robust. So the training must be holistic, must be rich, and it must begin. If it begins at that level, it must be very thorough. So the training is key in all this, because without training, whether you have the people, you have the processes, you have the infrastructure, all these things would not work. So training is very key, it's very important, it's very paramount that we train our students, we train our people to embrace, because in all this, people are involved. Just like what Mohammed Idris explained, investment in people, investment in processes, investment in infrastructure. These things have to be taught to the people. The people has to be trained on it, on how to manage it, on how to use it, and how to go on with the process, so that the benefits of electronic health and health informatics will be achieved. Thank you.
All right, thank you
Hello?
very much, Mr. Igudam. Yes, we got you. Thank you very much.
Professor Adeyele, would you mind if I jumped in to add just one quick piece of addition to the comment?
That would be great. That would be great.
Yeah. One of the things that I want to emphasize, as a previous speaker had just mentioned, and I very much appreciate, is that it's never too early to start teaching folks both health literacy as well as digital health literacy. If we look at the definition of e-health literacy, we see that it includes both the ability to seek information, to find that information, to understand that information, and to appraise whether or not that information is applicable or is important, right? You could think of these as being fundamental things, skills which are needed for digital literacy broadly. And if I can provide one interesting personal anecdote, one of the things that we saw with the pandemic is this kind of big push towards introducing technology into the classroom. And I can give you multiple instances where I would have cousins of mine, relatives of mine who were quite young, who in the first week or so of interacting on classes on Microsoft Teams and Zoom, really struggled in many ways, as did their parents. But what I found quite interesting, and again, this was very consistent across age group, across different cognitive developmental levels, so on and so forth, that it really was kind of this exposure early on and consistent exposure to technology that put them in a much better position to both understand how to use it and apply it into their day-to-day lives. And so beyond even introducing a lot of this material at the secondary level, the earlier that we can do it, the better. And I feel like there will be benefits to be had, again, thinking about digital literacy more broadly.
Thank you very much for that contribution.
Yeah, thank you. That speaks volumes, because it means we have to start rethinking on the most fundamental level. The concern here is, to what extent are we going to be able to push this at kindergarten level, primary level, secondary, and even at home? While Idris was talking seconds ago, my mind went to the home setting. What if we customize our television sets to be able to deliver basic lessons in electronic technology? What if the cartoons that we popularize help to promote the use of digital technology at the earliest possible age? What if the teaching methods are electronic methods, the learning methods, the examination methods? How far can we go in all of these? These are real big issues that we must deal with in Africa. There is the big issue of power supply, electricity supply, which appears to weaken the entire potential to develop electronically. It promotes analog methods of doing things, whereas we ought to be digital to be able to cope with large demands of data, access to data, use of data. All of these have very strong implications. So we have issues here to deal with. But first, we must start from where we are. We wouldn't wait to solve all those problems before we do what we can do. And that's what the University of Benin Teaching Hospital has exemplified. We're starting from what we can do. The hospital has stood out as an exemplary hospital in Africa, providing power supply 24 hours daily. And that's not because the national grid is doing that, it's because we have a leadership in management system in the hospital that places great priority on 24-hour daily power supply. It is very expensive, there's no doubt at all about it. But efficient management of resources has made that possible. And therefore, we can talk about digitizing health services in University of Benin Teaching Hospital. And we are moving more and more into the era where we have large volumes of data available, not only for decision-making, but for research. So thank you very much. We don't have questions from the participants. It does seem that everything is so clear, so crystal clear, that there are no doubts or nothing hanging. But just in case there are persons who still have some things to say, we'll keep the line on. But there is an issue I want us to quickly look at. I'll be very happy if Dr. Sonny Eyaro is able to address it. How do you cope in the midst of the investment climate? Let me put it better, perhaps. You are investing a lot into rapid medics. Do you have returns with which you can say that, yes, it's a worthy investment that should be widely promoted so that Africa and Africans can use local initiatives just as you have done to be able to build capacity? Or you think that the investment environment is discouraging and so we have an issue to deal with? Where are we?
Okay, let me come in here. Talking about the investment-wise in vis-a-vis the benefits, the cost-benefits analysis of adopting ICT in healthcare. I'll say this first of all. Let's talk about the benefits wise to the end user, to the institution that uses technology to drive their processes. Now, it has affected a lot of things in terms of, one, even their revenue generation normally goes up. Revenue generation goes high up. And then the efficiency of the system, how it is run, also becomes well-driven. And in Nigeria, for now, we are still not properly priced, and we understand why. So sometimes some of the projects we do in terms of investment benefits are not really there, but to stay afloat, you have to keep doing it until the time will come when it will be properly priced and it will have proper benefits in terms of the investment, so to say. So what I'm trying to explain here is that it is actually beneficial to the end user as far as the technology is appropriate, as far as the infrastructures deployed are okay, and then as far as the people are carried along in terms of training and migration and utilization. Now, so that's how it is. It is beneficial, but in terms of pricing, we are still grappling to get to be paid the way we ought to be paid. But that is not a problem. That is because technology has not been widely accepted. Then not only that, and with time, technology will become very cheap, especially if it is widely accepted. If it is widely accepted, that means many end users paying little money to the people developing the app and managing the apps. Then in that way, it becomes cheaper for everybody. But now there are too few persons, too few institutions involved in adopting technology, and they will not be able to shoulder the holistic cost in getting this thing running. So we have to make do with whatever come our way. That's how it goes. But it is worthwhile, a beneficial field, especially healthcare. Healthcare has peculiar data structure. It's not as simple as banking. Banking has their own structure that has to do with money, naira, and all that. But healthcare has special, well-structured data that differs from unit to unit. Like in antenatal, as I used to say, peculiar data. You go to anesthesiology, peculiar kind of data. You go to medical outpatient, an inpatient, peculiar kind of capture data. And so to customize those data, so that, remember, the standard we try to follow is that any technology you are deploying must be simple and user-friendly. And you don't stop at deployment. You keep customizing according to the feedback you get from the end user, so that you can keep adjusting the app to be more suitable and adaptable to their practice. That's how it goes. So it is actually really beneficial in the current sense, but with time, I'm sure it will improve in terms of that investment and aspect. Thank you. Over.
Yeah, thank you, Dr. Yaro. Carlos, do we still have you there?
I'm still here, certainly.
Great. Now, I was just thinking about low resource settings, which is one area where you seem to have some strength. And happily, you're based in Africa just now. What do you see as the prospects in terms of investment. You understand the economic environment, you understand the investment environment. What do you think?
Yeah, great question. I think it's one of the major challenges that we have, faced ourselves in many of the programs that we have supported. I think if I would say in terms of continuation of investment portfolios and funding for specific, programs, activities, one thing that I believe it's key and that we really have to address is the sustainability of these systems. So as we know, the hype of bringing innovation into a specific country, whether it's the usage of hardware at health facility level or tablets at the community level, smartphones, RDTs, readers, biometrics at different levels. It's quite big, and I think a lot of the funding agencies now are prioritizing that, which creates this sort of drive towards bringing mHealth solutions to the table, and that's great. We obviously want that to be that to continue and to continue to create value. Now the one challenge that we've seen that I believe it's important to address, it's again on sustainability of those systems, because many times we face two issues. Number one, various systems being created at the same time, addressing similar programmatic areas or pain points. And what ends up happening is that because the funding it's flowing for this type of projects, then there's a tendency of having these pilotitis or pilotitis in some cases, that's how it's called, where you have a lot of pilots kind of doing the same thing and further fragmenting the actual system on the ground. So these pilots, they come, they go, they might be actually very impactful or beneficial, but maybe the one pilot resulted into better yield of outcomes, and therefore the resources that were invested on other pilots, it's literally functioning through a year or through a couple of months, and then it gets thrown out, or the funding doesn't flow anymore. So one thing to be considered about is how do we, when available, these funding mechanisms can be focused on specific interventions that are not dividing the system itself, but rather focus so that the continuity of the tools or of the systems can go on. And the last piece, I think, is around sustainability. How do we make sure that that specific system or technology that gets adopted continues to be relevant for the country, for the government, whichever department this may be, and that I believe has to do a lot with local ownership of the system. So in many cases, and speaking about Africa, of course, but we have seen this also happening in Latin America. We have organizations coming, deploying a specific technology, and then removing themselves once the technology it's on the ground or is deployed, and leaving that technology without really having set a stronghold of local ownership that can maintain and can continue to improve the system in the years to come. And so focusing on developing that capacity of local institutions, local stakeholders, it's key for the sustainability of the system. So in that manner, all of these funding mechanisms, all of this financial support that it's given for these systems needs to address that sort of journey to self-reliance for different countries. So we have Ghana beyond aid, we have Kenya beyond aid, we have South Africa also moving to a journey to self-reliance. So that specific point it's very important for the continuation and for the proper sort of usage of these financial streams that support and implement this digital solution. So hopefully that makes sense, and happy to chime in on more on that if needed. Over.
Carlos, thank you very much for those very, very interesting insights. We'll get back to Dr. Mohammed Idris. I wouldn't know now how much of Eritrea you still know. Yeah, can you share with us your perspective from an African background? Do you have some experience in Africa that you want to share with us in 1 minute?
I wish I had more. I have my work has not touched as much upon the continent, and I know from the perspective of Eritrea, there's a lot of let's just say a lack of vision and governance from the top, and a lot of the issues that we were talking about early on, fundamental issues around power and infrastructure, that I think need to be put in place before having the conversation around training and the applications of the various technologies. But again, this is all based off of kind of anecdotal evidence and conversations, not as much work. So I want to preface kind of my conclusion with that.
Right, okay. Thank you, I understand you. I want to thank you all for all we have done so far. I think that brings us to, we're able to just look at 1 or 2 questions here before we just draw the line. I think some questions came late, or comments. One says, how can PPP help promote the uptake of ICT in healthcare and increase accessibility? Actually, what's going on now is PPP, public-private partnership. No government institution on its own is able to deliver e-health. What's going on now is that private industries are working hand in hand with governments to deploy that. The federal government takes that very seriously as a major approach to making it happen. Again, we really don't have an option because that is the most efficient way to go about it. So that brings us to the end of symposium number 3, which is the first for today. I want to say a big thank you to Dr. Mohammed Idris. We're grateful to Dr. Sonny Eyaro, grateful to Carlos Chirina, and thank you to Mr. Efosa Igoda. We appreciate you all for all your contributions. We thank the participants also for their different comments which they've made here and there. Thank you for your thoughts. We know that this is an area that will continue to demand some level of knowledge and practice and experience as we grow in our economy. We appreciate you very much. Thank you. It's exactly 11 o'clock, and that brings us to the end of this symposium. At this point, we're going back to Yerena Carlos, and we would like for him to give us an address, to give us a presentation from MEHID Incorporated. He has something to share with us, and we're going to do that right now. Thank you. Carlos?
Thank you very much, Professor. It's been a pleasure to be part of this panel. Would really appreciate the invitation, and allow me just to then start sharing my screen. Just give me a few seconds here. Hopefully you'll be able to see it now. Sorry, please let me know if you are able to see it. I think it's working.
Yeah, we're with you. We can see it.
Excellent. Thank you so much. Well, I think very much in line to our discussion and really towards this mHealth movement, how we can support our end users. I think it would be relevant to sort of share the type of work that we at DMAGI and with our flagship system, ComCare, are able to provide specifically to underserved, hard to reach areas where, you know, the access to health, it's challenged by many different variables. And so with our expertise, our technology, and our group of colleagues, we try to bridge this gap and to support these beneficiaries with the work that we do. So quickly, I'll just run us through who we are, our technology, why is our technology so powerful, but also how the technology has to be coupled with you know, services that allow this, you know, local transition and sustainability on the long run, as well as some specific examples of work where we manage national scale or have supported national scale systems, specifically in the African region. And so at the forefront, DMAGI as a social organization, we believe that supporting the last mile sort of service delivery, it's, you know, our ethos and it's our mission, and it's one of the things that drives our impact and our way of doing things. As the largest full-scale digital intervention in the world, we have supported, for example, in India, the deployment of over 600,000 community health workers, you know, deploying and conducting service delivery, assisted and supported by our technology. And obviously, we have helped the scale of this system to be at this level. So that just speaks to the robustness of our experience as well as our technology. As a mission, we're really trying to create, and here's the important piece, sustainable impact with these underserved populations that we have discussed earlier through two things, our technology and our services, so that, you know, one thing is the data collection piece, which is very important to provide visibility on what's happening in these areas. But also our aim is to provide and support the service delivery component in a sustainable way. I spoke about earlier about these pilot cities that tends to happen where in one country have different systems doing the same sort of or similar sort of work. And that just ends up you know, dividing and sort of fragmenting the actual system on the ground, lowering the availability of funds and creating barriers for sustainability in the long run. So as an organization, we were created in 2002 out of the MIT and Medical Harvard School in the United States. To date, we have over 200 staff members strategically based in different areas of the world. We have a strong presence here in South Africa, from where we deployed and support a lot of our projects, not only Southern and East, but also French West Africa and the North. Together, we have implemented over 2,000 projects in over 80 countries to date. So you can see where we are specifically and strategically positioned to support a lot of the work globally. Some of our main partners, as you can see, go from direct funding agencies such as the Bill and Melinda Gates Foundation, USAID, CDC, as well as international implementing partners, but most importantly and much more relevant to the sustainability and journey to self-reliance type of approach, local community-based organizations where we engage to really understand their pain points and issues, as well as local ministries of health, departments of health, and further on. I spoke earlier about how our experience has been mainly on health, but our technology and services are actually sector agnostic. So we have also supported agricultural extension work, in different parts of the world, as well as water and sanitation, education, governance, etc., etc. So that's how our organization is set up, and a little bit of the story. Now, in terms of our technology, our flagship product is called ComCare, and now ComCare, it's really a open source web-based interface that allows different organizations to create rather powerful, rather impactful mobile systems. And, for different programmatic areas, from supporting HIV control, for example, identifying HIV positive cases on the ground, referring them to the health facility to initiate ART treatment, as well as refer them back to the community to follow up on adherence protocols, to convey strong social behavioral change communication, to get rid of stigma and the sorts. That is the type of systems that we're able to build for different programmatic areas, RMCH, nutrition, family planning, malaria protocols, etc., etc. So with that, I think one of the core benefits that ComCare brings to the table, it's illustrated in this slide. So on one end, and I mentioned this before, we focus not only on the data collection piece, which is important, and it's very relevant to make sure that we know what's happening on the ground. That for us comes as a result of having a supported service delivery intervention. So our aim, as I mentioned earlier, is to build the systems with and along the stakeholders that are going to be actually using. Not only that, but also looking at the patients, looking at the clients, and different stakeholders, from M&E partners all the way to ministries, to see what is the type of data that they want to see, but also what do they want to achieve with their programs. Is it to reduce neonatal mortality? Is it to reduce malnutrition? What are the things that we are trying to really tackle, so that the system gets designed to really empower the user and not only use him as a means to collect data, but these amazing frontline workers are already in the front of the these underserved communities. So how can we take advantage and support them to carry on a better service delivery one day there? And so we can include multimedia, we could include images, voice notes, in local languages to further strengthen the service delivery component. The other piece that I would say that it's rather important from our technology perspective is the capacity to track information, cases, patients over a continuum of time, commonly known as case management. These allow us to capture information about a specific case, whether it's adolescent girls and young women, through dreams, protocols, and make sure that they graduate through the different services that they need to achieve, all the way to track HIV patients to see if they actually became co-infected with TB, and how now the treatment has to change and be different from what we were doing. And so that allows us to have unique identification number for specific cases. So if we are talking about Carlos as a specific case, we know that we are talking and updating Carlos's information throughout the continuum of time with one system. Thirdly, and I think quite important, is also the capacity of the system to work offline. I think one of the panelists earlier shared how infrastructural challenges are also one of the things that hinder the implementation of digital solutions. And so, electricity, data connectivity are one of the most common factors that affect these pieces. And so our technology, once it's downloaded into a mobile device, it's able to be accessed completely offline. So from the videos, voice notes, and the protocols that we put in there, you are able to access them offline, as well as the capture of the data that is required through the continuum of care. So once it reaches a point where there's data connectivity, then the data gets synced into our cloud-hosted server, and we are able to then access it through the web-based interface. And finally, I would say that the flexibility of the system, so going from a small pilot all the way to a national scale system, our team and our technology is able to accommodate both depending on the requirements from a programmatic perspective, as well as from a user perspective. So more programmatic coverage, more users as well. And just to give you a quick sense on how Comcare works, very straightforward. You build, you deploy, you collect and support service delivery, syncs back, you can review the data. And so we build out of this web-based interface that I mentioned, you're able to see and to previously, before you deploy, how the application looks, how is it going to be looking in a tablet or in a smartphone, making sure that it's collecting the data that we want. Later, we sync to the cloud, we download into the mobile device, and we're able to collect and deliver the actual service that we want to support. Again, whether it's programmatic area A, B, or C, our end users are supported and empowered by this tool. And finally, once this data is collected, once the service has been provided, it goes back to our cloud-hosted server, and then we're able to access that data through specific reports or dashboards within our web-based interface. One important piece here, and I think Dr. Mohammed alluded to this, is interoperability. It's very important when we're speaking about systems. So we, as the MAGI, understand that we play a specific role at the community level for supporting frontline workforces, collecting data, and engaging even with the end users. But we know that there are systems that are already legacy systems or preferred systems for reporting purposes, or even at the health facility systems such as DHIS2, OpenMRS. And so our Comcare system is open source, and its interoperability allows for us to collect the data from the community piece and then upload it and push it down to this other reporting system, as well as pull data from those systems as well. For example, in Mozambique, we have an OpenMRS bidirectional integration in which we pull index case patients to be followed at the community level. And once we follow, we can update the OpenMRS system back so that the latest information from the ground, it's updated in that system and be accessible for the different stakeholders at higher levels. And so that's the technology, as I mentioned, powerful by itself. But one of the most important pieces that we also bring to the table is our services and how they are coupled with the technology. And so with various years of experience implementing, designing, conceptualizing this digital system, our global team is able to support from the conceptualization stage all the way to the implementation these systems. I mentioned earlier our ethos around designing under the mango tree. So not designing anything from afar, but everything with a user design centric type of approach. And so besides the actual building of the system, we focus a lot on the local capacity building, transition of the system to local stakeholders to have a better sense and to have a better continuity of the system in the long run. And so we follow what we call the digital solution life cycle. And as you can see, prior to actually touching any of the technology of the robust Comcare capabilities, we engage in program design exercises with our partners, meeting with relevant stakeholders and users during our scoping phase to make sure that all of the requirements are well captured and we understand the local environment well enough. And only then we'll map out a system that will consider the technology as part of the program and rather to be siloed. And after conducting those 3 steps, we will then start to build and make sure that the quality of the system is there. So we take a very sort of important approach to understanding the local environment setting prior to building anything, because we want to make sure that this is something that it's important for the system to be sustainable in the long run. After that, of course, we are supporting the deployment. We are supporting the post-deployment support, training, and any other data pieces that might be needed. Another piece that Dr. Mohammed also shared with us was predictive analytics, artificial intelligence. We have also started to sort of support that level of data knowledge management, from the collection, interpretation of the data to hopefully be able to predict specific behaviors or flag at least cases that are at risk with the information that we have. And just to conclude, to give you a sense of our current presence, specifically in Africa, we do have, as I mentioned, other national scale systems in Guatemala, for example, in Central America, as well as in India. But in Senegal, for example, we have supported a national supply chain effort along with the government, with the Senegalese government. We have a strong presence in Senegal, as I mentioned, and an office in Dakar that allows us to sort of focus all our efforts in French MEHID-Africa. Burkina Faso also has deployed ComCare at the health facility level. So clinics are equipped with the IEDA REC system hosted in ComCare and continues to grow in terms of the coverage that the government wants to achieve there. Benin, we're planning to national scale the CHW system with ComCare. In Ethiopia, we're working with the ECHIS platform. In South Africa, we have supported the WBOT work-based outreach team effort. We have deployed over 8,000 work-based outreach teams are equipped with a ComCare application that supports, a various range of programmatic areas to identify cases at the community and then refer them back to the facility. In Mozambique as well, we have 2 main systems. The upscale system led by Malaria Consortium implementing partner, mainly focused on malaria type of activities, but also some nutritional aspects, RMCH component, and that has been rolled out to the different provinces in Mozambique. And we also have another system called InfoMobile, also developed in ComCare, that focuses mainly on HIV and TB, index case patient testing, PMTCT type of control, as well as a big component on loss to follow up. How can we identify potential cases that are going to be high risk of defaulting of treatment and take different approaches on how do we want to continue to have them on treatment. So I think I'm already at time. If there's any questions, I'm sure we're going to have some questions now, but further questions, here's my personal email. Feel free to visit our website, but also drop me any email in case you have any questions. We'll be happy to support. So with that, I'll conclude my presentation, but I'm happy to take any questions as they come. Over.
All right. Thank you, Carlos Shirina. That was very interesting. Tells us your business environment and how things have been in different experiences in different countries. We're waiting for questions, for comments and answers. As we do that, maybe Carlos can tell us a little more about his experience in the relatively lower resource countries. Let me tickle you a bit, Carlos. Why are you in South Africa? They've got money. Is that what's interesting there?
Great question. And, as I mentioned earlier, it's it's funny. So our South African office has roughly 7 or 8 years since it was created or funded. DMAGI overall, it's definitely older than that. But interestingly enough, the first sort of engagement that we had with relevant stakeholders in South Africa, it's only dated 3 years ago until now. South Africa, it's a bit of a different, as we all know, country in the region, namely, because of historical reasons, but also, as you mentioned, funding mechanisms, economical advances, technological advances as well. But it's a more mature type of, let's call it market in the sense of ICT for the mHealth solutions. So there's a lot of local organizations doing amazing work when it comes to digital systems, digital solutions, and mHealth. And so for us, having presence in South Africa was definitely important, just because of the country's relevance in the region. But honestly, as I mentioned earlier, the money component or the financial component is less relevant when it's not properly managed. Let me repeat that. The financial component becomes less relevant when is badly managed, if that makes sense. So certainly, we know that actually funding agencies such as CDC and USAID are already thinking of South Africa beyond aid. So there's talks already that the current wave of awards might be the last for the next 5 years, and then the idea is that South Africa becomes more sustainable by itself, and this sort of funding becomes less and more focused on other areas. I mean, we have Eswatini, we have Lesotho, just neighboring countries that are really struggling when it comes to achieving 95 epidemic control for HIV/AIDS. And so I mean, for us, it was strategic definitely to be here, but probably more for the region rather than for the financial piece that you mentioned, because again, reiterating, our main first intervention that it's worth mentioning only took place 3 years ago. Before that, most of our engagement was in Mozambique, was in Lesotho, was in Malawi, Tanzania, Zambia, I mean, within the region, but not necessarily in South Africa. Now, we hope that with the huge sort of focus that we're now getting in Ethiopia, we're going to be able to open an office there with local staff there. But I guess my final point would be financial support is definitely important. It's what gets us up and going when we design these systems and when we implement it. But it's not the only component. When there's buy-in, when there's a value on the table that we can bring, that's what drives us, the impact at the end of the day. If there's financial support, that's even better. But sometimes it's not the only thing that we will definitely look at. So hopefully that answers your question, Professor.
Yes, you did. I'm happy you responded very well. But it raises an issue. How much can we expect from multinationals in terms of contributing to e-health development in Africa? That's the bottom line. We're here not looking at just a matter of, okay, well, you're trying to satisfy yourself with the limited resources here. It's a question of relationships, building partnerships. It's a question of supporting systems to bring about best practices, especially the health industry in this case. So I'm just wondering, you've talked about financial mechanisms, you've talked about limitations. Yes, the more you're supported with finance, the better. Question, do you use the same model in every country? Is the model that you operate in South Africa the same as what you do in Malawi, what you did in Malawi, for example? What is the difference if a small African country is unable to provide financial or financing for the investments that you bring in, what do you do? Does the MEHID go ahead to make contacts and perhaps help to raise grants to support what it does in partnership with countries? You must be using different models, Carlos.
Definitely, and great question. Thank you so much for that, Professor. I think to answer your question, it's definitely different. However, there's a couple of things that remain the same. Number one, the value. So, it's hard for even you, on a personal basis, when you see value on something that you want to purchase, then the monetary perspective becomes less of an issue because you see the value that you're going to get from it. And so that value cost sort of balance is what we always try to bring to the table. So that sort of translates into the impact component. And so that never goes away, Professor. Definitely the channels in which we try to finance these pieces may vary. But just to give you an example, you mentioned Malawi, you mentioned South Africa, and also I'll put another example out there in Mozambique. So whenever we try to build a system, it can go two ways. One, an international or local organization already has received a grant or an award for specific work that they want to do, and they want to incorporate an mHealth solution, an ICT4D sort of system. And then it becomes a discussion like, okay, I have this amount of funding to implement this sort of work. How can you help me, Timagi, with your technology? So that's an approach. The other approach is, through the different funding streams that are floating out there from USAID, CDC, for specific countries, we reach out to different organizations and we, put on the table this opportunity. So we know that CDC is about to fund this HIV program in South Africa, 250 million for 5 years. How can we support you to, let's put together a plan, let's put together a proposal, and together let's go and bid for that specific award. So those are the two sort of main ways that we approach it. And obviously every country is different, every partner is different, so we will adapt our approach for each country. But those sort of channels are the main ones. Now, back to my point on value. There has been many cases in which we have entering, and I love the fact that you use partner engagement, Professor, because that's the right word. I don't think we're not in that commercial sort of mindset where it's a client and somebody providing a service. At the end of the day, it is, but we rather use the word partner because that's the way we like to engage with funding agencies, with implementing partners, etc. So let's say we build a system with a partner. That system we might do just for impact reasons. We might have like a bit of funding to get it off the ground. And then we suddenly hit a roadblock because the system is working well, but in order for the system to continue to be deployed, to be scaled further in the country, there's a need for funding. And so this is specifically the case of Malawi, where we had a system called SysToc that supported the supply chain sort of visibility of specific commodities all the way to the end user and to the community health worker, reporting stockouts, making sure that there is no delays on the resupply of key commodities. And so the system was impactful enough that was providing visibility to the ministry on where the bottlenecks were happening, where the big gaps were taking place, and through a dashboard, and they were very happy with it. But again, even at that point, ministry did not have enough funding to further scale the system to other provinces or other regions within Malawi. And so the value was there, but the financial support was not there. What the MEHID did then is, with a letter of support from the ministry, we went ahead and reached out to our network of partners, again, funding agencies or implementing partners, to seek for funding. And to my earlier point again, once the value proposition and the value perception was established, so the ministry saw value on this technology, the financial piece was less relevant. And we had people raising the hand, willing and wanting to support this system financially so that it could span further. So I think also that's one of probably like an overarching approach that we use, obviously depending on the country, depending on the context, depending on the stakeholders. But the MEHID would also go the extra mile to make sure that these systems become sustainable by reaching out to our network, by going after funding opportunities together. And when we hit a roadblock, trying to demonstrate the value that we bring in so that it can unlock specific funding mechanisms to continue to support the work that we've done. We follow the same approach in Mozambique through CDC. We have now over 6 years supporting the same digital system, and every year is a sort of an uphill battle to demonstrate the value, to demonstrate the usage and how this is really improving the lives. And again, once that happens through data, through dashboards, then the funding and financial support is it's easier to flow. So anyways, let me stop there. I probably went around circles there a little bit, but hopefully that answered your question, Professor.
Yeah, that got it. I'm happy you made it very clear. So it does mean that you have individualized approach to your business initiatives, and that you'd be able to enter into locally relevant, customized approaches, and what works for one environment doesn't necessarily work for another. I noticed too in your presentation that there was some kind of resonation about building, identifying the needs and going from the roots rather than you coming with product and say, buy my product. So that kind of partnership, I think, helps to encourage sustainability. I can assure you that if you work closely with us at MEHID-Africa, we'll be able to help establish some connections here and there with some communities, governments, and institutions in Africa, in other parts of Africa, especially Nigeria. Nigeria is the largest Black country in the world. You know that very well. Different forms of data have said that 1 in every 5, 1 in every 7 Africans is a Nigerian. That's likely true, and that means that we have opportunities in Nigeria. Of course, so many forms of companies are coming around to do stuff. But what is important is that we take it from the roots. That's why we have been so careful. It may appear slow in Nigeria, uptake may appear slow. It's because we're not in a hurry to adopt technology that is not operable or interoperable. So companies that are willing to discuss from the grassroots, looking at what is locally relevant and what is doable, are the kinds of companies that we sort of engage with in Nigeria. So you're welcome anytime you want to do that. And I'm happy that we have many other experts as participants in the event. That you have comments to make, questions to ask, Carlos will be very happy to respond to them. We have people from different professions here. You can see ICT experts here, nurses, doctors, some of who double as researchers and even serve also as teachers. We have many of them here on the panel, but we do know, as participants, we know that there are many others at viewing centers who may not show up on screen here. Carlos, you've done a great job. We appreciate you. In case there's anyone who has any remark, please let us know. Questions, comments? We have here Dr. Tosin Talabi. He's we call him class captain. He's here. We are all together with some of us in different parts of the world. We went to the medical school here together. He's joining in. We also have people like Sonia. Yes, he's in the panel. Edo nurse. That's in Edo State. He's a nurse. Clement Isibo, you're welcome. Higai Nabudoso is an obstetrician and gynecologist and is actively with us. We have several other persons who we may not be able to introduce right away. There are laboratory technologists here. Yes, so we recognize your presence and thank you for participating in this symposium, and then thereafter the presentation by Carlos Irina on behalf of Kimagi. Okay, Prud. Michael Prud has his hand raised. Michael, you want to tell us something? Michael, your hand is raised. Okay, it's down now. All right, thank you.
Yes, can you hear me? I actually had a question.
Yes, please go on.
Good morning, good afternoon, good morning to me.
Well, it's still morning here too.
Very much enjoyed the presentation. I had a question regarding the integration of the targeted community for the tools. It serves underserved communities. How much is there any process or operation to enable the people in those underserved communities to become contributors to that? In other words, to enable them into the development of those particular products and the likes. This was a question for Carlos.
Yeah, thank you so much. That's a great question. And as I mentioned, one of the main pieces that we use as the Maggie when we're building the system is number one, the digital life cycle for creating any system, which involves a lot of scoping, requirements gathering, and again this sort of piece of designing under the mango tree. Within that, the other component that we also bring to the table is that human-centered design approach. So again, once we conduct the scoping exercise and we design the system, this certainly takes into consideration all the feedback, all the knowledge, and all the sort of requirements that these end users, including patients, including doctors, nurses, and even M&E specialists, will require from the system. And the other component that it's important to note is that this is not a once-off sort of exercise, but rather an iterative process that, from there we will develop the first sort of version of the system. That system will go into, oh, sorry, there's a bit of a echo.
Right.
There we go. I think that's perfect. Yeah, so it will involve a iterative process, Michael, in terms of, we developed a version 0 of the system. We will then deploy it with a small group of users. We'll let them break the system, ask questions, play with it. We will then gather the information, create a version 1 of the system, deploy that version. But also, there's many things that we have probably missed or we will encounter as the system gets used more and more on the ground. So it's an iterative process where, the version 1 is already on the ground. We'll let it do its work for a period of time, but at the same time, we'll be gathering feedback from the field and then potentially create a version 2 of that. Maybe it's not only about the feedback that we get, but also programmatic areas that we need to now include on the system. We will create that and conduct the same sort of quality assurance, user acceptance testing protocols. So again, definitely, I think one of our main pieces that we bring to the table is the fact that we will never build something from afar, but rather taking into consideration the user as a center of any design decisions and requirements from an ongoing basis and on an iterative process. Hopefully that clarifies it, Michael.
Most definitely. It appears that you follow the standard software development lifecycle, but you're significantly dealing with focus groups and the likes to do user-driven design. Interestingly, I think I saw one part. I may have, and unfortunately I joined halfway through your presentation. I think there was some type of machine learning or AI component to some of the learning. Is that true?
That's true, Michael, and it's something that we are sort of including more and more. So we see it kind of in a pyramid type of approach. So if we think about, already 10, and thanks to Dr. Mohammed's presentation, if we think about 10 years ago, having data was one of the main pieces. So how can we get actual data from the field? Then the question is like, what do you do with that data? Well, you report on it, you draw conclusions, and then you hopefully modify the way that you are implementing on the ground. And as we move to that sort of engagement at the moment, I think in the last years and obviously now, this artificial intelligence, machine learning, it's also becoming a trend on, okay, now we have robust sets of data that are digitized. How can we prevent or preempt certain behaviors? How can we flag specific things on the ground that will help us to be ahead of the game in terms of the intervention that we're doing on the ground? So one piece that we have sort of done some work in is this defaulter predictive analytics. So on HIV/AIDS protocols, you have a loss to follow up a sort of case, which is that person that we know is HIV positive, but upon referring or trying to enroll them on ART treatment, we simply lost them because they don't arrive to the health facility or they miss their appointments. And so significant effort then it's put to reconnect with that case, make sure we change some sort of behavior or maybe some bias that they may have, and then bring them back to treatment. And so with this predictive analytics effort that we're trying to do, based on the information that we have, we now try to flag from the registration piece, so let's say we're registering Carlos, we test Carlos, and he is an HIV positive patient. Now, right there already, my predictive sort of model is telling me that Carlos, based on all the information that I have, has an 80% probability to become a defaulter in the next couple of weeks. So instead of letting Carlos go at that moment, I can take preempt action or preventive action to make sure that Carlos actually doesn't become a defaulter. And so maybe it's bringing them directly to the health facility, maybe it's conducting some social behavioral change protocols with him, et cetera, et cetera. So that's what we are now focusing on, Michael. But just to say that we follow a kind of crawl, walk, run approach. And that is to say that it's very hard to jump from like, okay, let's start to predict things where we don't have the data. And having the data is one piece, but also the quality of the data, that's another piece. And only once we run some reporting, we have robust data, then we're able to then draw some conclusions from that data. And so it's almost at the top of the pyramid and the cherry on the top kind of thing, but it does require a sort of structured process that allows to go from data collection, quality of data, maybe some reporting of the data, run some analysis on the data, and then be able to predict specific pieces with that data. Let me stop there, Michael, to see if that answers your question.
Oh, it definitely did. And it's interesting because you transitioned into my last question when you talked about the amount of data and the quality of the data. And it's specifically regarding culturally relevant data. Our studies and our experience is that, underserved communities and populations in underserved communities are underrepresented in training sets for machine learning. So we are looking at, the fact that there may be some bias in the underlying training data for the models that are used for things like sentiment analysis on voice analysis and things like that. And it would be interesting, your experience or your thoughts on that as you start to apply, your work in underserved communities dealing with machine learning.
100%, Michael, and that's why this sort of pyramid approach, crawl, walk, run type of approach is what we sort of follow. So we might land in a country with a specific partner, and they're like, okay, well, there's a lot of data around HIV/AIDS, and we can pull, from our experience in South Africa and our experience in Lesotho to do something here in Mozambique, for example. And the first approach to that is like, well, that's great, but we really need to localize, the data that we're collecting or the data that we will be working with to the specific environment that we want to predict. Number one. And so even if there's, research data from elsewhere, we really need to look at the quality of that data to make sure that we are avoiding this bias that you mentioned. And so, it's very exciting to talk about AI and machine learning, but sometimes we have to slow down our partners in understanding that is a process that we need to first make sure that we're collecting the right amount of data, that our sources of data are, like you say, not biased, that are really focusing on the target areas that we want to achieve these predictive analytic effort. And only then, when we have that set of data, then, take this further into trying to predict and having some models that are relevant to the population, because there's the case of imaging testing where certain conditions that happen in the skin would look completely different from a clear skin, a black skin, a more dark skin. I mean, and if your database, it's just considering all the information from a European database or the sorts, then you're completely going to be mismatching and mismatching your results if you want to apply that in Africa in general. I mean, that's completely a different pole. So that's very important, Michael, and that's one of the things that we take into consideration, because we don't want to, number one, overpromise something, and also we want to minimize the bias in as much as possible. Over.
Perfect. Thank you so much, Carlos.
Yeah, Michael, I can tell that you're digging deep into very important issues that have to do with business, real business. Otherwise, investments will be wasted, and the expectations may not be as expected. I have often wondered how data from Europe, from other places are used to predict populations in another setting. But I think now that from what I'm hearing, you also have that as an issue, which is not an easy thing to do. So there must always be caution. If an investment into e-health fails, all parties suffer from it. That's what I've seen. The external investor and then the population that's expectant, they're all left hanging. No progress, nothing done, because not enough plans were made or expectations were too high. But these are pretty difficult things to do. That's why it's always good to use the kind of approach that Carlos talked about: crawl, walk, and then run. You don't just get to think about a destination like AI. You just want to have AIs. For what? Does it help Can you afford it? Is it necessary? Is it a priority? Those are the kinds of things that must always come up whenever thoughts are on about deploying new technology. There must be clear road mapping, and the business part of it is absolutely important. In the next symposium, which comes up at 12:30 Nigerian time, that's 39 minutes from now, Michael Prude is going to be leading us, and I see the questions he has asked as prelude to that symposium. So thank you very much, Michael. I want to thank Dimagi, particularly Carlos, was very well represented his company. I want to thank his team, quite a few of them who I've been talking with for some time. The arrangement for the appearance was quite at a very short notice, and they were able to respond very well. It shows that they are very serious about partnering with Africa, and we shall have conversations hereafter. I'd want to enjoin the participants to also take advantage of the access that Carlos has provided. By the way, Carlos Urena is accessible on LinkedIn. Just browse for Carlos Urena. He has also shared his email address with us, and we may want to continue conversations from there. Thank you very much, Carlos. You want to have one or two final remarks before we close, Carlos?
Thank you so much. Just to thank everyone for the time. Professor, I think you summarized it quite well. And just to say that agreeing with you, we want to partner more with our African counterparts, different stakeholders. This is an amazing time to do very impactful and great things. So please do feel free to reach out. We're always happy to have these conversations and find ways in which we can collaborate together. So just to open the door for further collaboration, we'll be happy to also be connecting with MEHID more and more. And we believe this is just the beginning. So thank you so much, everyone, for the great questions. If you need or have further comments, remarks, or questions, again, my email is there. And yeah, thank you so much for the opportunity. Appreciate it.
Yeah, thank you very, very much. Please, our warm regards to Katrina. She was very useful in the initial contacts that made it possible for us to meet here. I also acknowledge the works of Godson Eze, Dr. Godson Eze, the head of HIV control program in Trinidad and Tobago, who helped to reach Dimagi in the first place. We acknowledge your contributions to this conference. We appreciate you very much. Now to the entire house. At 12 noon, we're going on break, but right now we can as well start the break. So at 12:30, we come back, and we shall be with Michael Prude as he takes us through business models. Thank you very much. We go on break now. Good afternoon, ladies and gentlemen. You're welcome to the next session. We are on to join the to start the next symposium, which is on business models for the deployment of e-health and health informatics. And I can see Michael adjusting his seat, super ready to give it to us. At this point, I'll simply introduce Michael Prude as our symposium lead presenter. He's based in the US. Michael Prude combines many backgrounds. He will soon tell us more about himself. But one thing that we know for sure about Michael Prude is that he's an engineer with broad expertise in technical implementation, which is an application of implementation science and functions very strongly as a business process management expert. Michael Prude has been with us since the beginning of the symposiums, since yesterday. He has been with us today. We're happy that he's ready to give us the very best that he has been preparing for. After Michael Prude's presentation, we shall move on to a panel discussion, at which time I shall be introducing the panelists. But before I go on, I just want to introduce my colleague, Dr. Michael Ezeanoche, consultant obstetrician and gynecologist, a very proud user of health informatics and e-health in his practice and providing leadership in it. Thank you very much and welcome, Dr. Ezeanoche. At this point, I just quickly request that Michael Prude takes on the stage to please tell us more about yourself and then take us into your presentation. You're welcome, sir.
Thank you very much, Professor Adelaide. If I may share my screen.
Very well.
Okay, perfect. Can you see my screen?
Very well.
Thank you very much. Can everyone see my screen? I just want to see if I'm presenting well first. Hello, hello.
We can.
Okay, perfect. Thank you for that kind introduction. My name is Michael Prude. I am the president of Urban Outsourcing, working closely with Dr. Francisca Pamel and Dr. Elizabeth Ofili at the Morehouse School of Medicine. It's a pleasure and an honor for me to actually be involved in this activity today. I have traveled extensively through Africa, spent a lot of time in Zimbabwe, a lot of time spent time in Senegal in Northern Africa, but I have never had the privilege of going to Nigeria. And Dr. Pamel, of course, tells me that Nigeria is the center of the world. I'm quite sure she's correct. Today's topic is going to be somewhat interesting in a span of time because business is always interesting, specifically when it comes to people's lives. So I wanted to touch on today certain business models and really speak about, business opportunities or where I see business opportunities in the e-health and health informatics space. 2 minutes of a little bit of background. How did I get here? Urban Outsourcing is a for-profit social venture. What does that mean? It's a organization, a company that I started 12 years ago when I saw a gap, a significant gap in the actual STEM, science, technology, engineering, and math fields. My background is in information technology. Prior to actually starting Urban Outsourcing, I owned a publicly traded information technology company that we were traded on NASDAQ. And we specialized in providing financial service solutions to technology solutions to financial services companies and to pharma. One of my biggest clients was Pfizer. We did a lot of their systems with respect to their actual clinical trials. We did a lot of work in the actual trading space. And I had the opportunity, the distinct opportunity, to follow the technology industry over 35 years, from mounting tapes on mainframes to mobile development and distributed processing and intelligence. And in my travels as a young man of color, coming from a humble background, one of the things that I noticed, which was very troubling to me constantly, and I tried to rectify it in my company, but decided to, once I sold my company and retired, to dedicate myself to that, was the gap of representation of people of color in the STEM industries, and the long-term impact that that would have on us from an economic perspective and our participation in society as it moved into the information age. I also noticed something very interesting there, and that was my emphasis was on system integration, enterprise architecture, large trading systems, large, very complex financial systems. And at the core of that was intelligence. And the interesting thing about that was that I watched the phrases change. We left from enterprise information management to data processing to business intelligence to now data science. And so I watched the evolution, and I noticed more than anything else, the prevailing importance of intelligence more than anything else in the business world. And again, how we, people of color, were not really included in that opportunity. So when I sold my company and retired, or sold out of my company and retired, I started a for-profit social venture to drive inclusion of people of color into STEM and into these areas. And specifically, the reason you named Urban Outsourcing is because we did a lot of outsourcing to India. We had 4 facilities in India. And I noticed that the IT world could be treated as a skilled trade instead of a professional venture, where you can take programmers and the likes without college degrees and employ those and change the economics of our community. So I did that in the United States, in New York for years, continuing to do management consulting. And that idea came to me from a symposium that we held in Hyderabad, where we brought a number of Indian individuals together to pitch ideas to us on an annual basis of how they can start for-profit social ventures to change their communities. Things like microcurrencies, mobile internet, and even mobile health. Fast forward 11 years later, and I'm at Morehouse School of Medicine, providing management consulting services to the All of Us effort, which is a huge NIH study around precision medicine, and for Dr. Pamel, and start to understand that the same gaps that I saw in the information technology field was actually a serious issue when it came to public health and health equity. So a little bit of background about why, because it imposed upon me a need to say that business for us had to have a public benefit. So let's talk a little bit about, some traditional healthcare business categories based on my experience. And bear in mind, I come to the field from the outside. I come to the field from what I like to call the shark business capitalist outside. And I believe in what I call compassionate capitalism, the ability to do business that actually affects change. But at the same time, it is still business. It's still the process of making money. So we have basic products and services. And in the product side, of course, there's standard in the healthcare industry. The biggest product offerings you probably are seeing are the EHR vendors, the Epics and the Cerners of the world, and the device manufacturers, and even the ancillary auxiliary fitness device ones, and medical machines and MRIs and XYZ. And then, of course, the biggest part of healthcare is the service industry, the provision of service to those particular patients and the likes. But what we see, which is common between those, forgive me, which is common between those, is the rise of intelligence and the importance of actual intelligence in the industry itself. That intelligence has, over the last 10 years, or the need for intelligence, and what I mean by that is not only informatics and analytics about disease and treatment, but about lifestyle, interaction, and wellness. Interestingly, what you started to see is a lot of introduction of private sector concepts into the healthcare business, specifically when it comes to intelligence. And so what I would like to focus on today is specifically business opportunities in healthcare, which revolve around intelligence. So there are three key intelligence categories that I find very interesting in the e-health space. And not only interesting because of the monetization capability of them, but because they're also socially impactful. First, general area of machine learning. In an earlier conversation with the principal from Demagi, who, excellent presentation, by the way, I asked the question about machine learning. The challenge and the interesting thing about machine learning for myself is that we've watched it evolve, and I've watched it evolve over the years. I've been involved in AI for probably 15 years, and I've watched it move from being in the ivory towers of academia or the back halls of doing derivative calculations, which I was doing for trading floors, to being so much more accessible because of the availability of tools and code that allows us to be more accessible downstream. But that market is huge. Accenture estimates that the machine learning market, which is basically the basis for which you're actually able to drive AI and predictive analysis and the likes, will be approximately $6 to $7 billion in 2021 for healthcare alone in the United States. And the interesting thing about that for opportunity is that the social impact of that deals with the question that I asked the principal from Demagi, and what is the representation of underserved communities in those models, in those training sets? I work with Morehouse on a program called All of Us. All of Us is a precision medicine program that was actually an outgrowth of an effort by President Obama when he decided that he wanted to move the Medicaid more from providing health or benefit from what we call fee-based to value-based. And what they understood was that there was a significant underrepresentation of underserved communities, what we call UBRs, underrepresented biomedical research participants, and that there needed to be some concerted effort to have more people participate in that. And in participating in that, you needed to have an understanding of how to reach those people. Okay, and why was that important? Because the training models that were being used also in analysis, we were not resident in. And so a very interesting example is, and I'll speak a little bit about one of the platforms that we use, and later on in this presentation, a product that Dr. Pamos is very much associated with, as well as Dr. O'Feely, is when it comes to the point of recruiting. I had a very interesting experience recently, right? Well, not even recently. As part of I put together a program for a framework for the organization, because one of the challenges with clinical research is recruiting, and it is actually meeting your participant recruiting goals. And one of the biggest challenges you find there is when you're trying to target underserved communities, is the ability to bring those people in because of traditional challenges with trust and privacy and security issues, return of value. So a very interesting thing happened. We employ a call center software, and that call center software has the ability to use AI using natural language processing, which then determines performs sentiment analysis on the call. And we use this to actually do training and coaching of our agents when they're reaching out to resources to actually recruit them into the program. And as part of the evaluation of the platform, we had to ask the question, well, when you did the training of your NLP model for sentiment analysis on the actual conversation, what was the cultural makeup of your training data? And the answer was, we don't know. And what was the relevance of that? It was relevant because we understand that in underserved communities, communities of color, we're not monolithic, and that the way we speak is different than the majority. What may be perceived as aggression, what may be perceived as resistance, may be just a cadence and cultural affinity, maybe a cultural affectation itself. And it was immediately obvious, as continually obvious, that again, using the data from that particular type of scenario may in and of itself be flawed. So one example, opportunities in machine learning, and I'll go further into that. Secondly, population intelligence. As I was speaking earlier, the trend in the United States, and we see it in other countries, of course, is a move from fee-based medicine to value-based medicine. The rise of Obamacare and the explosion of healthcare costs in the United States says that there needs to be an emphasis on results instead of just fees. And so population health management, or population intelligence, is the area of basically looking at clinical outcomes and improving those clinical outcomes in defined groups, right? By tying it to improve care coordination and using particular financial models. How do I reimburse? How do I get a return on my investment? How is the importance of patient-reported outcomes and actually recorded outcomes? Huge market, but yet again, those markets are requiring significant amounts of data from underserved populations, which they do not have access to. And not having access to that data changes their ability to actually prove the result. But there is a serious demand and requirement to get access because in, for example, the United States, a significant part of underserved communities are on, say, Medicaid. That market in 2019 in the United States was valued at $14 billion. And what are some of the benefits of that? By improving the lives, the social impact of underserved people in underserved communities. And I'm speaking in the United States. You start to increase health equity. You start to increase the prevalence of value-based care. And you start to actually increase what we call UBR optimization, the underrepresented biomedical representation in clinical research, so that we can improve precision medicine results. And then finally, something which is very focused. I think in Dr. Pamel's presentation, she may have spoken about this, and this is based on her studies, and she's done excellent work in this area, and that's the rise and importance of culturally congruent communication. The interesting thing that we find in care and treatment is that, of course, everyone knows there's implicit bias. And a lot of that implicit bias in terms of, a good example is, I was reading something interesting and disturbing. Amongst African-American women, pregnant women, regardless of socioeconomic level, the mortality rates during treatment for pregnancy is higher than the majority. And a lot of that is not tied to their education, it's not tied to their economic situations, regardless of socially economic status. It's because of bias in the system. It's because of the ability to actually meet that patient where they are from a cultural perspective. Dr. Payne may have spoken about studies that has happened through Morehouse, where they found that the changing downstream impact of changing lifestyle choices and behaviors for chronically ill patients was significantly affected by the content, the cultural congruency of the actual communication with the target audience, the venue, and the communicator. And so we're doing work using machine learning and studies through the programs to understand and implement and integrate that into the communication for recruiting for research, for coaching downstream, and we will talk about that. I'll talk about that a little bit later, and for the provision of care. So let's dive into machine learning a little bit, and its interest. Again, there's a gap, and we can speak about, and there's a gap in the models, but there's also a gap in those people who are involved in the field that represent us. But there's opportunity, because what we have found is that access to your community has, of course, both the power to impact it socially, but it has monetary value. And as long as that access is done for the public good, it serves both purposes. 20 trends that Gartner identified, Gartner Group, in 2020 regarding machine learning. I wanted to speak about, touch on just three very quickly. First trend was decision intelligence. The embracing of the analytical data for the purposes of making decisions, not only in diagnosis, but also in the actual provision of care. Interestingly, the example that I gave with just attempting to recruit into programs or even schedule patients to come in, specifically patients with chronic care issues, chronic illness, or providing actual coaching models, which I'll speak about a little bit later, right? Should be that should be intelligence based in terms of how we curate communications and structure and script the communications with that, instead of it just being ad hoc. That's a very pointed example of using decision intelligence for a very targeted result. But that is happening significantly. I come from the private sector, spent a lot of time working with clients in the marketing space with doing analytics and the likes on how do you actually do drip marketing and targeted marketing and high personalization itself, and bringing those capabilities to the medical profession in terms of their communication is critical. Second thing, data itself, marketplaces and exchanges. the monetization of data has been happening forever. If you look at Google, if you look at Facebook, if you look at most of the huge technology companies, their business is data. And the interesting thing about their business being data, more than anything else, is that they are actually monetizing that data, but having access to that data or getting that information from our communities is challenged significantly. And we are the gateways to that. Not only do we have the ability to ensure that that data is accurate and representative of who we actually are, but that the actual economic benefit from the access to that data is maintained within our communities. Gartner predicts that 35% of large organizations will be either sellers or buyers of data. That's something to stop and focus on. 35% will be sellers or buyers of data. I can tell you in the financial services world, that has always been the case. 100% of financial services companies sell or buy their data. But in the e-health space, because of HIPAA requirements and security and things like that, what we've seen very important is having access to that data and monetizing that data has been a little bit more difficult because of interoperability issues and privacy issues, but it's there. There is a trend that you're seeing, for example, in Apple with their HealthKit tool to the democratization of patient data in the United States by making EHR records available, and there's actual laws behind it, at the device and owned and transportable by the actual patient or owner of the data. And so that trend is already existing, but what there are opportunities for us underserved communities to make sure that we not only participate in it, but are actually see business and financial benefit from it. And then finally, blockchain. Blockchain's value is that it helps in the democratization of data because it allows you to not only determine about the ownership, but to actually give secure control regardless of place. And that's very important because one of the things we do a lot of work on is interoperability between EHR systems, which is one of the largest obstacles to data sharing. Now, why are these particular trends related to machine learning? They're related to machine learning because the core of most work with machine learning, as most people will tell you, and Professor Mohammed may have spoken to you earlier, is the access to the training data and the data preparation piece itself. And that is actually ridiculously key. Okay, one very quick example. Tombool, a company coming out of Nairobi, Kenya, they actually used machine learning at the point of care with a product which is used to actually do diagnosis on respiratory results. It takes the sonic image and it uses machine learning models to actually determine if there's any issues at that level. And the fascinating part about this is that it deals with two of the issues that I'm actually speaking about, three. It deals with the data. It deals with basically empowering the doctor in a place where they may not have the infrastructure necessary to to actually have extensive technology capability. Okay, so it allows it to be remote, and it actually takes that data and continuously trains the model in underserved communities. So they have a model set which is built and drawn from their population, which they can continually learn from. So it deals with all three of some of the challenges I spoke of earlier. That particular solution uses Google TensorFlow. But what's important here is the accessibility of machine learning for the purposes of actually creating business which wasn't available before. And that is the advent and the growth of what we call the no-code cloud-based machine learning movement. And some examples of those are what you see down at the bottom: Azure ML, Google AutoML, and obviously AI, which are no-code solutions, which you can use to build models and do machine learning without having to have the added significant expense of high-priced data scientists to some extent. You will always need that. What I'm really speaking there is access. And the interesting thing about business and what the cloud has done and what a lot of the internet did is it lowered the barriers of access, which was challenges for underserved community and entrepreneurs who did not have access to capital as well as the majority. The playing field has changed. Population intelligence. I'm going to speak a little bit about Health 360X, which is a platform which is developed at Morehouse by a company called AccuHealth. Dr. Paymo is involved with that to some extent. I work with that effort itself. Population health management, key. We spoke about this. When I touched on this earlier, it really speaks about the nexus of actually having a social impact, but having business at the same, but doing business at the same time. 3 core components of population health, according to Gartner Group. Performance management, which is the analytics and the likes, intelligence once again. Care management, how do I provide care? How do I use the intelligence gathered from the performance piece itself to provide care? And consumer engagement, how do I actually communicate, recruit, train, educate, influence that patient population, okay, all tied together to provide one thing, okay, improved health outcomes. That improved health outcome is extremely important in our community. And as you can see, as far back as 2006, they talked about the indirect cost of inequity in expenditures that can be reduced just by changing health outcomes in minority communities in the United States. The cost savings are tremendous, $230 billion, close to $1 trillion. And interestingly, the business of healthcare in the United States is about cost reduction more so now than anything else. But if you can provide value with cost reduction, if you can change mortality rates and increase the quality of life while reducing costs, there is significant earning capability. And what has the trend been on this? Class Group 2019 did a very good classification of some of the players in the population health management space. Okay, with respect to the underserved communities, it's about reducing the health equity gap. But really, you'll notice that a lot of these players on here, Epic, for example, Cerner, those guys are people who are coming from the actual EHR space, which is a space which is really developed over time to be far more focused not on the actual medical records, but on analytics and finance itself. And then you have the big technology players. You look at IBM's Watson Fitel there, and Google's actually involved in this also, okay? All of this is about collecting that data and then taking that data and selling it back. This is the monetization of data, the monetization of intelligence. Again, what is that opportunity in eHealth for socially impactful ones? It's ensuring gateways and participation as frontline collectors and owners and manipulators of that data for this larger scenario. Population health. Finally, culturally congruent care. I mentioned that I would speak to you about a platform known as Health 360X. Health 360X was developed at the Morehouse School of Medicine and taken out as a population health management platform where we're incorporating into it the best practices and understandings of providing culturally congruent communication to make sure that we provide culturally congruent care. So what does that mean? There are 4 different components that we deal with. One, we want to deal with addressing the whole point of engaging the patient or engaging the potential research participant through targeted education. Targeted education is using private private sector marketing, communication, multi-channel communication, omni-channel capabilities, right? Infused with language which is relevant to them culturally to drive calls to action. And that calls to action is about proving lifestyle, education about the decreasing fear, improving intelligence about condition itself, all for providing a better quality of life and understanding of the changing lifestyle. Study recruitment and retention, which is huge in underserved communities. The NIH spends a lot of emphasis in the United States on UBR, as I mentioned earlier, underrepresented biomedical research participants, and ability to get to them. And that opportunity is not only strong, but very important itself. And then at the practice level, the ability to recruit and retain and continually communicate with your patients, regardless of whether they are actually sick or not. Making the doctor's office or making care something which actually is an ongoing thing through communication and the likes. The next piece is capture, the ability to actually start to bring in data. So we support multi-device capture from blood glucose levels and blood pressure and the likes. And we also have integration from fitness devices. We also support integration into the from EHR itself, from the purposes of an actual registry used by the practices for clinical research to providing analytics downstream in terms of how we actually can provide care. My favorite piece, of course, analyze, the intelligence piece, which actually fuses the intelligence about the health outcomes, patient-reported outcomes, social determinants. For example, looking at other external information aspects such as food deserts and the likes, which have impacts on health and quality of life, the effectiveness of regimens and the likes, UBR analytics, how effective we are in terms of the demographics of the population, the cohorts that we're actually bringing in, and the impact of the actual culturally congruent communication piece itself. And then finally, that's a closed loop, a Deming type process, which is brought back into the care piece itself so that we can provide personalized coaching. The platform allows for participants to be attached to coaches, to have regimens for them. And one of the ones recently launched was around lupus, for example, where you can train actual coaches. Those coaches themselves may be people with the disease, have life experience in it, and they're trained to provide coaching capability, provide coaching services to other patients and the likes, either through the practices or through other research projects or through private concerns, and providing personalized care regimens to them. So the business world in e-health. There was a quote years ago that I used to use before I sold my larger company, and it was called, we laughed, we called "It's the data stupid." When we look at the business models for e-health, the traditional ones jump out: products, services, devices, software. But what we really see is the real business model. More than every one of the business models, right, will be impacted by securing the intelligence about that population, owning quality assuring, and exchanging the intelligence that's derived from those devices, from those services, integrating those into a continuous improvement loop to constantly drive better change outcomes, where remuneration comes from decreased medical costs, improved quality of life, right, and downstream environmental improvements, improved public health equity. Thank you for your time. I'm now going to open up the floor to questions.
Yeah, that was great, Mike. Nothing less than what I expected. And I've seen that there are more and more insights into the way we think about business models. I must confess that you took me into some dimensions that I didn't even imagine. And I see more and more proximity, more and more tie-up between all the presentations. The investments are related to people, behavior, cultural relevance is important, even the building business models and so on and so forth. I must thank you very much. Yeah. At this point, we're moving to the moving on to the panel discussion. I'd like to introduce two other members of the panel. There are people who we have come to know in the last few years in Nigeria because of their great contribution locally, making impact on how healthcare is delivered. First, I'll introduce Dr. Charles Akimia. Dr. Charles Akimia is a medical doctor, co-founder of Mobicure, 2018 to 2020 UN SDG Young Leader Mandela Washington Fellow, Obama Leader, One Young World Ambassador 2017, UN Global Impact SDG Pioneer. He created Omomi, a mobile platform which consists of a mobile application plus web app plus SMS service, with which pregnant women and mothers of under 5 children, maternal and child health FTs. Mike showing interest in this for years and has continued to promote its use and has shown interest in reducing maternal deaths through different forms. He has conducted trainings, is inspiring young people and passing on very basic lessons that are understandable at community level. You're welcome, Dr. Charles Akimia. Charles, are you there? Okay. Okay, we have a small technical hitch. We shall soon fix that in a moment. I'm going to go ahead to introduce another panelist. That's someone whom I have come to nickname Sajay. Is Mr. Ugochukwu J. Chikezie. Some people may not know him by that name because his product has taken over his name. It's Tremendoc for short. He's the founder and chief executive officer of Tremendoc Limited. Tremendoc is a telehealth solution that enables people to receive medical care consultations via chat, audio, and video calls. He has used modern ICT to affect a wide range of human endeavors. And he says that his goal is to use technology to enhance the healthcare sector in Nigeria and Africa at large. Jay, as is fondly called, or Tremendoc, has keen interest not only in health, but in several other industries. But his passion is very strong in telemedicine and telehealth because he wants to make the health sector function differently. You're welcome, Sajay. We'll just have a short break and we shall get you back online. Hello, we're trying to overcome the technical hitch we have here. May I ask if Michael Prude is still online? Are you with us, Michael?
Yes, I'm still here.
Yes, the system has automatically made you a host, so you please, if you can operate from your end, please restore Sam MEHID-Africa as the host. That will solve the problem. Okay.
Will do. Let's see.
Thank you. That means you'll be our host someday.
There you go. How was that?
Yeah. Are you back? All right. Thank you. You have solved our problem. Thank you.
You are very welcome.
Right. So great. Thank you very much, Mike. So we now have Charles Ahimie, whom we have introduced. We also have Jay Chikezie. That's Tremendok for short. But I've just nicknamed me Sajay. They're both on board. So Charles, you're welcome.
Yeah, thank you. Thank you very much for having me.
Sajay, you're welcome too.
Thank you. Thank you for having me. I'm happy to be here.
Thank you. Sorry for the brief hitch we had. You heard Michael's presentation. Can we get your initial insights, please? Charles?
Yeah, I mean, so my insights, first of all, Michael, thank you for your really great expose. For me, I've always been fascinated about the fact that when it comes to healthcare, it's important that even though healthcare is viewed in most places around the world as a social service, it's important that health technology or do operate from using business models. So it's important that you operate health innovations, e-health as businesses, and it's important that you operate them from the bedrock of business models. So I remember when Michael was talking about the fact that even though he's fascinated about doing business for good, right? So even though it's business for good, it still is a business. So that part really struck with me. And I think it's something that perhaps healthcare entrepreneurs, especially in tech, need to always remember that at the end of the day, even though we're making a lot of impact, it still must remain a business. So that was my key takeaway.
All right, thank you very much. So, Sajay, can we hear from you?
Yes, so I think I'm very big on intelligence, and I heard him talk a lot around intelligence and taking information and trying to improve, the healthcare system, especially in Nigeria and Africa. I think it's very important. E-health providers in Nigeria, I'm an advocate to say, having streamlined your data and be able to give intelligent outcomes, about making possible predictions of, on disease outbreaks in different parts of the country or parts of Africa, and kind of help the Ministry of Health or the relevant bodies in trying to curb, those outbreaks. So I think that that was really interesting for me, getting intelligent information from your systems, or whether it's a solution or it's a software, or from the data of the customers or that have used your system.
All right. Thank you very much, Jay, for your comments.
I think I want to pass my comment across to Michael Prood based on his presentation. So Michael, if you're listening, you try to look at your business model around machine intelligence, machine learning, AI, and population intelligence. I think they are quite relevant for Africa and Nigeria too, where the equity gap is quite wide between those who have access to resources and those who do not. But a big problem we have is this absence of the necessary infrastructure to layer on this business model and to quickly start making business inroads, despite trying to make impact in healthcare. In your opinion, what do you think Africa and Nigeria needs to do to be ready for these business models and opportunities that you just talked about, considering the absence of the necessary infrastructure in terms of e-health to implement them?
Excellent question. I'm sorry, there was a little bit of echo in the background that I heard, but I think the question was in the absence of maybe some infrastructural components, what are some go-forward models that can be used in Nigeria/Africa around e-health business models?
Yes, exactly.
Okay. Yeah, excellent question. I think I find it interesting. One of the things, and I may have glossed over it, was what I call the democratization of technology. When I started off 35 years ago, 36 years ago in technology, access to technology, it was this dark art. And what I've seen, programming and data modeling and the likes, it took forever to do. It was not readily available to the general public. And I'm talking about in the United States. And so me being an African-American in the United States, think of if 1 in every 200, 300 people in the United States back then was in data processing, imagine how many African-Americans was in it. We was like 0.1%, okay? But the world has changed. And some of the things you saw me touch on, for example, with respect to machine learning, was the fact that what we have done is we've gotten a no-code movement. No code is a very strong development movement where people without significant coding backgrounds can now start to develop programs and the likes, and specifically develop programs around using machine learning. Good example. For years, I have worked with a robotics team here in Atlanta. Dr. Lonnie Johnson is very well known. He created the Super Soaker. And so he's well known for that. But he's a technology pioneer in that he has maybe 145 patents. He put devices he designed that went on the Voyager mission and the likes. And there is a first robotics program that exists here. And what I do is I mentor and teach 12-year-olds how to program robots. So I'm giving you a part of access. And these 12-year-olds do not come from upper middle class families. They come from working class, regular middle class, and poor families. So what I'm saying is that they face the challenges there because what I have access to is low code or no code coding tools, if you follow me, right? So that makes it more accessible. And then additionally, even though, you when you talk about infrastructure, I presume you're talking more about network or infrastructure, telecommunications, right?
Yes.
What those allow you to do is it allows you through virtualization, because I used to do a lot of work in virtualization. Virtualization is moving away from the need for necessary hardware and virtualizing. When you go to Amazon, AWS, or anything like that, those are virtualized. That you can make your one box, your one server look like many servers. And interestingly, what that allows you to do is it decreases, it gives you what we call, gives you hardware density, but you can then take that one server and set that up in classrooms or in a company and then have it make it look like 4 or 5 without having to then connect out, if you understand what I'm saying. So it kind of allows you not to be constrained by some of the infrastructure issues itself, and you can do that localized. Then, if you have that brittle connection that maybe not, his name is not there all of the time, you can then move those models or those pieces up to the cloud, okay, and run those on a pay by the drink model, right, without having to be constantly connected. So what I'm actually saying is this: there are ways to actually, we are expert at innovation based on need. And in the technology world, what has happened because of the advent of the cloud, where you can be occasionally connected. People speak about constantly connected. You can be occasionally connected because of the rise of the no-code movement and the rise of what we call serverless computing, which allows you to write key things in simple languages that only get run once without you investing in the hardware. It lowers the barriers of entry. And those things apply in e-health. And so the Tombu example that I gave, I think is one of the best examples, because that's sitting there with development which could be done locally, could be done without connection necessarily to the cloud. You can train those models locally, if that answers your question. You follow me? Okay. And then take that device and walk with it, use it in that community, and then occasionally connect up to get the bigger data. And then I'll end with this, I'll end that touch with this. What a lot of this has done with the proliferation of mobile devices is the processing power of mobile devices, right, is phenomenal. Currently, if you look at what Google is doing, most of your AI machine learning work that you do in Google, and Google's major language is known as TensorFlow, which, by the way, I teach my 12-year-old kids in robotics, right? Runs on the actual phone. So do you see how you kind of disintermediate the need for that network all of the time? So that runs locally on the phone. So the combination of no code development, right, which makes a lot of IT and technical people, they would challenge them. Oh, you need us. No, you don't need us as much as you thought you did, right? 2, the advent of virtualization. You can put appliances in local places that run virtual service, 5, 10, 15, 20, 30 of those at a time, right? And so create an environment, a development environment where they don't have to communicate as much and be connected and have that hardware infrastructure investment to the same extent. And thirdly, being occasionally connected to the cloud to then run those processes when you need to. All of those lower the barriers of entry caused by infrastructure challenges, because you can do it over low latency type of networks. I hope that answers your question.
Yes, thank you, Michael. You just provided very interesting insights, and it kind of resonates with what I was thinking. So for Africa and countries that have challenges with infrastructure in trying to deploy e-health, virtualization is very important. And then, of course, they have to connect to the cloud and bypass the challenges of infrastructure. And it is interesting that you also talked about mobile devices. And that's relevant in Africa, where we are seeing more than 50% of the population, including rural communities, having some connectivity to the internet through their mobile devices. And that presents an opportunity to deploy e-health solutions. So thanks for that very enlightening response to my question. I would want to get back to Charles. Charles, tell us a bit more about Omomi, your product, and how you think it links up with the response of Michael to the challenges in Africa and Nigeria in terms of deploying e-health solutions?
Okay, yeah, thank you. So Omami is one of our products actually. So in the summary, that's the only one we talked about. So just very briefly, so I'm the co-founder of MobiCure, and MobiCure is a health tech company. So MobiCare actually has two products. Omami is the older one. It's for classic maternal and child health app where moms can get access to doctors, get access to health information in an online forum, and do a lot of other stuff like track immunization, monitor, even do diarrhea monitoring and growth monitoring and all of that. And we started Omami in 2015. The platform has a little over 40,000 registered women till date. Our more popular products, which is the one especially with young people, is MyPaddy. And that's a classic sexual and reproductive health app. I'd say the push to do that product was, we saw that with Omami, now mothers are a very different target market than young people. They have different concerns, they have different needs. So we decided to do MyPaddy to really tackle a lot of the things that we saw with maternal indices, to really start it earlier. So MyPaddy is a sexual and reproductive health platform, which we offer users a layer of anonymity. So you can sign up on the app and be as anonymous as you want yourself to be. You can also do some of the similar things moms can do on the Omami app. It has a telemedicine component where you can chat with doctors and counselors, which is extremely popular. But as a platform, we have evolved, which is what I'm big on for health tech, of being able to evolve. And we've also incorporated an e-retail service where young people are constantly looking for products, whether it's contraceptives, whether it is test kits for HIV and all of that, and then providing these services in a discrete delivery service. MyPaddy is outperforming Omami, obviously, because it's young people, it's a different market. I mean, as at last week, we had 85,000 users already on MyPaddy. We are really positioning our platforms to, especially with MyPaddy, to be one of the foremost and purely sexual and reproductive health platforms for young Africans. So a lot of some of the stuff that Michael talked about is stuff that we're already doing. For example, on both platforms, we've already started, on Omami, for example, we already have a live chatbot. For us, the reason was twofold. One, running a platform for 5 years plus, or cumulatively 6 years for both platforms, we are sitting on a fair bit of data. As you would imagine, we have tens and thousands of conversations between doctors and patients. So in order for us to scale, we cannot keep increasing the amount of physical doctors to meet up with the amount. I mean, MyPaddy, for example, has 85,000 users. So if all of them decide to chat with the doctors, we're probably going to need to have maybe 2,500 doctors, which doesn't make economic sense. There's just not even that many Nigerian doctors even available for that type of work. So one of the great things an AI would do, which I know Michael knows all about it, is it will help us automate a lot of our process. So currently on Omami, which we are testing it on, a patient can have a live chat with a bot, and then the bot will basically do symptom analysis, collect the patient's history, just analyze the symptoms and then send a summary to a doctor. Mm-hmm. So at that point, the doctor is basically going to get the summary of what the bot and the patient has discussed, and then can make informed decisions. So basically cutting down the time which the doctor would have to interact with the patient, so making it more efficient. So it resonates a lot with what Michael is talking about, really using the data that we have and using machine learning to be able to, apart from the fact that to be able to, make better health decisions, to be able to even scale. So that's small part of what we're doing. Thank you.
Thank you, Charles. I think it's quite interesting, especially the part where you talked about using artificial intelligence to scale up the work you're doing with economy, because clearly we do not have that amount of medical doctors in Nigeria to meet the needs of people.
I thought, sorry, Michael Prude again. I thought Charles actually very excellent. I thought it was very fascinating. Charles just brought up something which was very interesting. And correct me if I'm wrong, Charles, he needed to solve a problem that all businesses which they had, right? He had too many people and too little resources, right? And he had to scale. We love that term scale in business because scale means I have business, right?
Yeah.
But he turned that challenge, right? The use of chatbots, which interestingly is again an example of integrating private sector marketing technologies, right, into e-health, right? So many times I'm finding, it's interesting, I'm relatively new to healthcare, that it tends to be closed in the thinking, right? Not invented here. Instead of having a private sector perspective and going out, so I bring to my solutions and my consulting solutions, what we learned in financial services, in trading, in stock and brokerage, in marketing, right? But I thought it was interesting, not only that you did that itself, because that's very prevalent in marketing, using chatbots and AI behind the scenes. But even more interestingly would be analyzing those conversations for the benefit of clinical research.
Yeah.
Because we have to be careful with that again. But again, the underrepresentation for us in clinical research affects precision medicine, the way pharmaceuticals are made, the way decisions are, health is distributed, if you follow me, clinics, if you have socialized medicine, all of that is impacted by it. But the point of the spare is what you're doing in the conversations you're having, all of that intelligence and analyzing that. And then I'm going to use that dirty word, selling that data. Because the reality is, as plain as it's kept, I have a quote. I have this saying: a mission without a motto, a mission without money is just a motto, right? It's just a bumper sticker, right? But if we can do that ethically, socially consciously, right? To be the gatekeepers to the intelligence about our community, which you are gathering ridiculously important, specifically because of your demographic. Younger people, sex, right? Ridiculously important information itself that the larger organizations want, and that we need to actually be gatekeepers too. So I'm very much interested. I loved what I heard when you said that, specifically about using the chatbots itself. You used it to scale, but there's an intelligence monetization opportunity there.
Thank you, Michael, for that feedback. I think the conversation is getting more interesting. So I would like to get to Jay Chikezie. Jay, so share your experience with us in terms of delivering mobile health solutions.
Yeah, thank you. Thank you, guys. And thanks, Charles, for that insight. It's good meeting you here. I think I've tried to see if I could reach out to you so that we could do something together. Maybe that will be after this. So about Tremendoc. I registered Tremendoc in 2017. My first tech company was NairaBox. It's quite popular in the lifestyle sector in Nigeria. We I created that. I founded that in 2015, where we're able to aggregate with the cinemas across Nigeria and concerts to sell digital tickets. And then in 2017, I founded Tremendoc. Like you said earlier, Tremendoc is a mobile app that allows our users to talk to doctors, whether it's through chats or audio or video call. We've been able to successfully do about 100,000 plus consultations on the platform. This is since 2019. What happened, there was a gap between 2017 and 2019 where I had to remodel the business. I shut down the app around that time, and then we recreated and developed this new app and launched in September of 2019. And since then, it's been amazing. We've had over 100,000 consultations on the platform. We have about 1,000 plus doctors, and how this works is because of the partnerships we have. We have partnerships with hospitals, like for instance, Lagoon Group of Hospitals, Lagos State General Hospitals are onboarded on the platform, so their doctors are available on the platform. What we provide is this using technology. We're leveraging that for the state hospitals, or it's the private hospitals, where users can actually do follow-ups with their doctors on demand on the platform, or schedule an appointment where they still meet their doctors remotely. We're very big in partnerships. So what we've done is partner with even financial institutions where they're able to provide, free consultations to their customers. And then state government insurance, we work with AXA Mansard, we work with Hygeia, we work with Novo Health, provide remote consultations for their enrollees, and it's been amazing because what we've seen is that 70% of the consultations that people have to go into the hospitals to consult with doctors can actually be done remotely. And we're doing this and getting the kind of data and information that we have seen in the past 2 years. It's just amazing how much remote consultations can do. We had a feedback from one of our HMOs coming back to say that they had a reduced payout to the physical hospitals, which is quite expensive for them. So what this is doing is reducing the amount of money that they pay out to the physical providers, right? And what we're doing now is creating an ecosystem on the platform. So on Tremendoc, we have a partnership with MedPlus, which is one of the largest pharmacy chain in the country, where people can actually, get prescription from doctors and then book their pickup and pay directly on the app, and then pick up from the nearest MedPlus pharmacy, or get delivered to their homes. We also have a partnership with SynLab as well, which is the largest laboratory chain in the country, where people can book their tests, and then they actually send health providers into their homes or offices and take samples, and then these tests are analyzed, given to the doctors. These doctors can book an appointment with you on the platform, and then you're able to, interpret the investigation done and then prescribe drugs with the same process. So what we're doing is creating an ecosystem, a 360 ecosystem remotely on the platform, so that people can, especially during this pandemic, but beyond that, we found that in Nigeria or Africa as a whole, there's a culture where, because of the amount of doctors available to us in hospitals, and little or no hospital infrastructure enough, across the country, you find people who have already gone to, using their pharmacies as their hospitals. So they go there and then they tell this pharmacist what the problem is, and he prescribes the drug, which isn't the right practice. Or people just go to self-medication or call their moms or the dads, and then they give them, you know, one drug, prescribed drugs for them because it has happened to them, you know, in the past. And they'd say, oh, I took this particular drug, not putting into consideration, you know, the person going through it, you know. So what we're trying to do is say we're providing convenience. So if that was your reason for not, you know, going through the right channel, actually going to the hospital, you can still meet your doctors here, and then you can still run your tests, and you don't have to leave your house, and then you can get your drugs delivered, you know. And so it's been amazing since we started, and we're looking forward to doing, you know, greater stuff with this.
Thank you very much, Jay Chikize. I think your exposition was quite interesting. I'll take some highlights here. You've done over 100,000 patient encounters or consultations. And I love the way you forge partnerships with health insurance organizations, hospital chains, laboratories, and financial institutions. And some of what you say resonates with the presentation by Michael, where he talked about the need for linking e-health, clinical research, and outcomes. And like you pointed out, close to 70% of the consultations you had through your platform appeared successful. So these patients never really needed to present physically in the hospitals. And that's quite interesting. That's solid data. So you could look at extra outcomes, how satisfied were they clinically, what were the outcomes, and all that. So I don't know, Michael, your thoughts as we run down.
Yes, I just couldn't understand the question. Could you please ask that again?
Listen to Jay's comments and presentations on the number of patients they've seen, and being able to tell us that 70% of the consultations were satisfactorily resolved by the doctors through the platform online. And so it resonates that you can look at your data, you can analyze your data, and you can actually find out how effective you're doing. So I think it tallies with yours. So I was going to ask if you could share your thoughts with us.
Yes, definitely. So interestingly, there's a trend. We saw it start and stop in the United States. Google and Apple, for example. Very interestingly, Google introduced something. It's not completely related, but it has some relevance to it. When the COVID outbreak happened in the United States, they wanted to do contact tracing. Google built that into the OS where you can have presence detection. Now there was privacy issues in XYZ. What am I saying? There was an understanding that the mobile device is the device now, in that the capability of that mobile device, as the gentleman was talking, right, is powerful, in that it doesn't disintermediate the doctor, but the technology and the actual software has created scenarios where it allows for self-service by, as I think Mr. Charles was speaking about earlier, by analyzing the data with the chatbots to determine what answers you can give and how to give it to the doctor, but also by optimizing the experience so that a lot of the upfront work doesn't have to be done. And so I think that ties into the question about how does that serve a country like Nigeria or African countries which have challenges with network infrastructure, number one, because a lot of that can be processed on a device. But I think just as importantly, it ties into, you know, the experience that the patient has. I think what was described and what was very attractive about it was that the more you improve the patient experience, just like you improve the customer experience. And I tie this to marketing and everything else because we have emotional decisions and our relationships and DAX are emotional, right? That type of consultation done that way gives them an immediate result and changes and has an emotional impact on them, which for the doctor creates what we call stickiness. It keeps that patient attached to them. right? Okay, because a lot of times, specifically amongst men, we don't go to the doctor, right? Our wives tell us to go to the doctor, right? So it changes that dynamic, right? But it also allows, therefore, to be a better training and education thing. I talk about that in L360X. We have a similar mobile app which does that. We don't do as much consultation though. But I believe that that is not only future facing what he discussed, but I was actually impressed about the number of consultations that are there. I think that will be explosive, interestingly. And I think it's little things like that that appear to be small, which are actually transformational in the e-health industry, right? The ability to change the patient experience and have the sense of immediate access by combining intelligent technology, AI, and things like that, remote technology, and personalized results. So intelligence plays such a role in creating an emotional bond between the patient and the provider, and also the quality of the actual treatment itself.
Thank you very much, Michael. So we are coming to the end of this session. It's been nice having our panelists contribute to the conversations. We've heard from Michael sharing models on the deployment of e-health with experience from the United States. And then Charles and Jay, who are actually deploying e-health solutions in Nigeria, sharing their own experiences, and we can see the interconnectedness of what I've been talking about. Artificial intelligence can help us to scale population health and population intelligence from the big data we are getting. And then also trying to deploy mobile technology to deliver the service. And as Michael says, always to provide care in a culturally appropriate way, such that the user experience is unique. So you can recruit patients and you can retain them, and then stickiness, as we describe it. So I want to thank our panelists for today. Michael, you've been great, you're wonderful, we appreciate you. Charles and Jay, you are filling the large gap in health services using technology, and the opportunity is huge because the gap still remains and the needs for health services. And I wish you well in the future endeavors. We thank our audience and participants who have listened to the panel discussion. And then we'll prepare to go for a short break, lunch break for about an hour. And then we'll see you all again by 3 o'clock when we go to the next phase of our symposium, road mapping for the deployment of e-health and health informatics, practical perspective. So thank you very much, and have a nice day, gentlemen.
Thank you. Thank you for having me.
Thank you for your time. Thank you for having me.
You're welcome.
Thank you. Thank you very much.
Ladies and gentlemen, good afternoon. It's 3 p.m. and it's time for us to go into the last session for today, the 5th symposium, symposium number 5, the third for today. As usual, the symposium is going to have be made of a lead presentation, followed by a panel discussion, and then comments, questions, and answers. Right now, we have in the house respected ladies and gentlemen. I recognize people from UK, Dr. Angela Asom, Dr. Nicole Saji, Dr. Sonia Yaru, our resource person, and several other persons. Dr. Evere Ehize, Harry, you're welcome, Jimoke. Now we need to call our lead presenter, Dr. Olajide Adebola. He's right in the house. Okay. All right, so Dr. Olajide Adebola is a medical doctor who has uncommon passion for e-health and health informatics. He organized in his early days as a young man, a young doctor, he organized small meetings until he grew to large meetings in e-health. More than 10 years ago, he organized the first national e-health conference in Nigeria. He's ex-president and founder Society for Telemedicine and E-Health in Nigeria. Dr. Olajide Adebola went on to do a master's degree in global health, in which he specialized in e-health and health informatics. He actually did his studies in health systems, and he's a business leader. His career in e-health has been for about 20 years. Yes, he's been about 20 years into e-health with focus on M-health. And his interest in M-health, of course, is based on the fact that in many resource-limited countries, access to M-health is high. And it is one way to quickly scale up e-health practice and services. He's into telehealth in diverse ways, in research, in public health practice. He's very much interested in user-centered designs. He's currently the Chief Technology Officer and Partner, Home Plus Medicare Services Limited. Panelists, participants, we welcome Dr. Olajide Adebola. You have the floor, sir, Dr. Adebola.
Thank you very much, Professor Adeleye Omokai. It is indeed a privilege, and I count it an honor to be part of MEHID-Africa, its maiden edition, and to be speaking at this 5th symposium in an all-week program. I'll be sharing my screen right away. And good afternoon to all panelists and attendees in this conference. Please, can you see my screen now?
Yes, We can.
Very good. So I'll be speaking on road mapping for the deployment of electronic health and health informatics. My outline of presentation, I will take us through some definition to provide a context for the discussion. I will introduce the subject matter and then describe the process involved in road mapping for e-health and health informatics, and then talk about the deployment of e-health and health informatics in itself. And then I will conclude the presentation. So by way of definition, Saban and McCormick in 2015 make us to understand that there is a convergence now between the healthcare sciences, computer science, information science, and cognitive science. And at the center of that integration is to assist the management of healthcare information. So I believe in the last 2 days, we have talked about health informatics, e-health. I felt it's important that we look at this definition as we start road mapping for health informatics. So we have healthcare sciences, we have computer science, information science, and cognitive science in order to support the management of healthcare. It's a cross-sectional technology in itself, and therefore a lot of information engineering takes place to improve healthcare service provision. Electronic health, simply put, as the use of ICT for health by the World Health Organization in 2005. And by 2020, the World Health Organization came up with another definition that has become the center stage of this field today, known as the field of knowledge and practice associated with the development and the use of digital technologies to improve health, which is digital health. So, and in its trying to define the digital health, it is said to have expanded and over the concept of e-health, because now we have digital consumers, that is consumer informatics or consumeric informatics, where people use quite a number of smart devices from their phones, their wristwatches that can also do some physiologic parameter monitoring over a distance, and then connect these technologies to the Internet of Things, advanced computing, big data analytics, artificial intelligence, which includes machine learning and robotics, makes digital health a bigger field than e-health. So for the purpose of this symposium and the sub-theme which I've been given, I will restrict my definition to electronic health and the health informatics space. By way of introduction, currently I'm a national digital health consultant with the WHO, and I'm supporting the Federal Ministry of Health to review the National Health ICT Strategic Framework. And interesting enough, is one of the documents shared for the third day reading today. What I've observed over the past years, and which I must commend Professor Omaka Adelaye and the Chief Medical Director of UBTH, as well as the Vice Chancellor of the University of Benin for putting up together MEHID-Africa. It is important that we begin to build our own local technical capacity, skills, and knowledge in e-health and health informatics. The Dunning-Kruger effect has not left the e-health space alone, and this in itself has contributed to project investment that has remained siloed to this effect. You realize, for instance, in the same city like Federal Capital Territory, that is Abuja, you have general hospitals digitized with electronic medical records, but each time you visit any of these 11 out of the 14 general hospitals that are functional, and you have to start all over to register into different electronic medical records, stored away in different databases, and so we don't have the integration. And so this is further leading to this further leads to fragmentation of health data and health information, which will not be available for either improving services at the facility level or for the planning at the health administration level. So the inadequate technical capacity and skills and knowledge over the years, particularly in developing countries, has also contributed to non-scalable, unsustainable, and failed projects. But we must remind ourselves that strategic planning is at the heart of every successful venture, intervention, including electronic health and health informatics. In fact, it is said, if you fail to plan, you are planning to fail. So, quickly, examples of project failures that we have seen in health and health informatics that makes it necessary for us to roadmap for the deployment of e-health and health informatics. We have issues like limited design at conception, not planning to scale. Most of the projects became siloed or unscalable because they were use case rather than business cases. Certain risk assessment were not done, how to mitigate and manage those risks and implementations. Because of time, I will dwell on the first context, which is what happens in our environment. There's quite a number of donor projects across the sub-Saharan Africa supporting electronic health and informatics. And there was sometimes in an EU country, help middle-income country, where because this technology worked by the European Union, who is the sponsor of this particular project to create immunization registry system. The system was deployed in the middle-income country. And what happened after? This particular system didn't take into consideration the local environment and its context, and therefore, at the end of the day, it was difficult to access the database directly. The people, the users, the end users at that middle-income country abandoned the system. So what went wrong? It is likely that enough time was not spent planning and designing the project. It was simply assumed that what worked in one country will work in another. Many factors, not simply functionality, affect feasibility and usefulness of a system in specific country. This is available online as a resource, particularly for public health managers. So road mapping for e-health, health informatics is very important. And I put up a definition here for road mapping for e-health, which is the strategic process where we determine the actions, what to do, the steps, how to do them, and then the resources that are needed in terms of technical, human resources, the timeline, the funds required so that our e-health and health informatics initiatives can successfully be taken from vision to reality. That is road mapping. The World Health Organization in its Global Strategy for Digital Health 2020, a publication of WHO, said that a part of road mapping is to consider either at the national level, at the sub-national level, or even at the facility level. For instance, the University of Benin Teaching Hospital, or any organization that is ready as a proponent to make use of these tools to strengthen health services, which is the theme of MEHID-Africa this year, must consider to draw up a long-term strategic plan for its developing and then implementing these services, which requires critical infrastructures for ICT. And of course, the reality is to promote equitable, affordable, and universal access. So all of this emphasizes the importance of road mapping for electronic health, health informatics at any level. Now, to start with, whether you are at the national level, whether you are at the sub-national, the state, or an institutional level, it is important that you understand the e-health environment where you are. It is said that strategic thinking in the right environment and with the right, for the right reasons, and then the right actions will produce at the right time, right results. So therefore, understanding the national e-health environment, the sub-national e-health environment is very important. So that forms a context for the development of e-health for road mapping. This is taken from the National e-health Strategic Toolkit 2012, a joint publication of the World Health Organization and the International Telecommunications Union, ITU. This particular figure shows from early adoption stage and experimental stage, which is on the negative side of the y-axis there, you see that the enabling environment for e-health is just emerging. And then you move up to stage 2 or phase 2 of the national e-health environment. That is, you're already developing and building up. So what's the difference between the emerging enabling environment for EHEAD and the established and the developing and building up is the fact that your ICT environment is established. Now you have domain names .ng, you have domain registries available in country, you have internet service providers, you have also policies, you also have an ICT, national ICT policies. So all of this contributes to developing and building up. The third stage of the national EHEAD environment that enables road mapping EHEAD for successful creating initiatives from vision to reality is mainstreaming. This is where you have scale up. That shows that it's a fully established, not just the ICT environment, but also the components that enable EHEAD to thrive. So it's important to know which of the stages, whether experimentation on early adoption, developing and building up, scale up and mainstreaming in the environment where you want to roadmap for EHEAD resources, because that will determine the kind of actions, the kind of steps and resources that will be required. Very critical, the component of that enabling environment was divided into 7 thematic areas, which is leadership and governance, very important, strategy and investment, legislation, policy and compliance, work infrastructure, services and application. Services and application. So these are the things to look out for. These are the elements, components that makes you reach maturity or scale up, whether at the institutional level or at the subnational level or at the national level. Without the availability of a workforce that is skillful, don't forget in my introduction, I said the inadequate skills and knowledge of the workforce contributes to the unscalable as well as unsustainable and some of the failed projects we have seen in the last 2 decades. Lack of adequate legislation and policy, both to protect the provider as well as provide means of reimbursement, is also a challenge. So you can begin to see, and that helps you to know what kind of EHEAD and informatics services you can deliver either at the institutional level or at the facility level. This is also from WHO. I have a bit of a technical delay. My system is hanging. I hope I'm still audible to all the participants.
You are to me and the people in the control.
So my laptop has refused to change the slide. Let me try. All right. Go to slide number 8. Go to slide 9. Go to slide 10. Sorry for that delay. So road mapping for electronic health informatics is very important, knowing that the infrastructure, services, and applications constitute the ICT environment, your strategy and investment plan, your leadership and governance for e-health, your workforce, your legislation, policy and compliance, your architecture, standards, and interoperability constitutes the enabling environment. The presence of these right environments makes resourcing for electronic health and informatics to be easier without having them. It brings the right environment that enables you to tap into the potentials of this technology. So there are processes already laid down when most national governments requested the World Health Organization and the International Telecommunication Union to provide a guide for road mapping for electronic health. This applies at the national level. It also applies at the subnational level as well as the facility level. Number one, you have to manage this process. And in managing this process, you have to set up a sort of a task force or a committee to look into road mapping for electronic health or health informatics at any of these levels. The most next important step to take is to engage with stakeholders, broad stakeholders. I'll be sharing who are these stakeholders. It's very important. They must also own the process and they must own the outcome, which is the roadmap for the deployment of e-health and electronics health. And the next thing is to establish your strategic context, looking at your national health policy objectives, plans, to see where e-health, health informatics resources, health informatics services, its products and tools can help achieve the strategic objectives of the national health system. If it's at an institutional level, such as the University of Benin Teaching Hospital, you want to look at the services that is being provided, what are the goal and objective of the University of Benin Teaching Hospital to its environment, to the neighboring states, to the country as a whole, and transborder. And all of this is put into strategic context to draft an initial vision. You also learn by gathering information on the e-health environment, as discussed earlier, from the trends and experiences that is happening nationally around the neighboring state. For instance, I'm using UBATH now, engaging in this roadmap development, and at the same time, use all of that to craft your vision for our strategy. Don't forget that road mapping is actually these actions, the steps, that resources that help to determine what you do to take a vision to reality. So now we can now draft the vision. The National Health ICT Strategic Framework 2015-2020 has a vision for Nigeria, and it says by 2020, health ICT will help enable and deliver universal health coverage. But therefore, there are certain components, there are certain actions that are required for that vision to turn to reality. So you move to the next stage, which is to identify the required components in the national e-health environment. What services and application will be deploying? Is it telemedicine based on your strategic context? Is it mobile health? Is it telehealth? Is it laboratory information system? Is it a data collection tool? Is it patient follow-up or patient appointment system? So that is why it is very important so that resources will not be put to waste. And it's important to also look at the opportunities and the gaps that are there already in terms of the ICT enabling environment and the ICT environment, the e-health enabling environment, as well as the health environment, the population health and health data of that community. So, and at the last stage is to refine your vision and develop strategic recommendations. So this is the 3 steps to quickly what I've just shared now. Step 1, initial vision is drafted, from managing the process to engagement of stakeholders, having your strategic context, gathering information from the e-health environment, looking at the opportunities, what are the gaps, the risks, the time frame, and all of that helps you to know what components that can be delivered realistically. Don't forget, road mapping is to turn all your visions and initiatives in e-health and informatics into reality. And the next step is to review the outcomes. What will be the benefits to University of Benin Teaching Hospital, the benefits to patients? At the national or subnational level, what's the benefits to government, the health administrators, the healthcare providers, and the consumer of health services? A realistic time frame that will get all of these resources together to take the necessary actionable steps to turn the vision to reality. You revise the components or the time frame again, and then the last phase, you assess commitments is very important. Who will fund this particular initiative or activities? And then who are the bodies committed? Is it a government-sponsored project, donor-sponsored? We'll be writing proposal how to philanthropies. Is very important as part of road mapping, and then you can now refine your vision. That takes us to the stakeholders' role. Very important. There was a training last year, capacity building for ISO guidance for national standard bodies. I also chair the National Technical and Mirror Committee for International Organization for Standardization Technical Committee 215 on health informatics, which has adopted the 2 Nigerian industrial standards for health informatics in Nigeria. So in road mapping for e-health, These 7 categories of stakeholders must be represented. People from the industry and commerce, government, consumers, labor, academic and research bodies, standards applications, non-governmental organizations, because why? It is important to tap into the knowledge and experiences of every stakeholder because of ownership. When I was involved in a project at Federal Medical Center at Kefi as far back as 2011-2012, we set up a committee, and it was chaired by the Chief Medical Advisory Committee head and the CMAC, and then it involved every other department within the hospital, because the introduction of this technology bring about emergent or at times incremental changes that will require change management, changing way how people receive care, assess care, or even conduct their work process within the facility level. So it's very important to ensure that stakeholders own this process when road mapping for e-health. So after your strategic recommendations, you have your vision, the next thing is the actions line. You need a framework. So, and what do you want to see in that? You need your outputs. Those are the resources for the activities to be carried out, the risks and the challenges if we do it, because you need to have change management in place. What resources do we need to implement those actions? Skills and expertise do we have? If we don't have those skills, do we get a consultant? Do we hire a firm? Okay. What sort of high-level resources do we require? Do we need to have a hospital-based, facility-based strategy or policy in place, guidelines for the use of e-health and health informatics in our establishment? What sort of funding requirements is very important? And also the next phase is the implementation phase of the strategic phases. And therefore, it must have a strategic focus, and then your targets is very important to say, when we deployed so application for telemedicine at University of Benin Teaching Hospital, it is expected that 100,000 patients who had no business coming to the emergency room will stay at home, make necessary consults, triage over the application or the teleconsultation that frees the emergency room to attend to emergent cases and emergencies, life-threatening cases. What you have done in that case is that you have already know the resources that will be required, the tools that will be in the consumer's hand, and that allows the hospital to have cost savings. Also, the consumers have cost savings, and then expertise that are needed at the ER are planned for, and then more life-threatening cases can be attended to, and bed spaces are available at the emergency room. So these are the kind of things that takes place in road mapping for e-health and health informatics. Most importantly, the third part of your roadmap is that you must use a result-based management framework for monitoring and evaluations. Very important to know how far you have gone with the actions, your action plans for your e-health and informatics, both in terms of the inputs, the activities, the outputs, and what are the expected e-health outcomes? What are the changes that introducing this technology can measure them? That you are able to convince your superiors, you're able to convince the authority that deploying digital health, electronic health, and health informatics is actually achieving the set target. In summary, don't forget steps for road mapping. You have to manage the process, and therefore there must be a team, a task force, or a committee to manage the process. Stakeholders are very important, key influencers within that community that this technology is being introduced. The strategic context needs to be established, and then we need to learn from trends and experiences from other places like we're doing at the MEHID-Africa conference, and then we begin to draft our roadmap, know the required components, gather more information on the e-health environment is very important, and there are policies and legislations that we need to be aware of so that there can be return on investment and then assess opportunities and gaps. This is how a sample structure of what your vision will look like. Once you have this slide, you can look at it. You can see the section on the strategic context. You can see the vision for e-health. It's very important to have vision. Without vision, it is said that the people perish. So it's also important in road mapping for electronic health and health informatics, a very clear, articulate vision that is realistic. Of course, the foundations for change are the enabling environment, which constitutes of the ICT as well as the e-health environment. So all of these 7 components must be there with your recommendations. Quickly, I want to move to deployment, which is very important. This is now at the project level. This is at the implementation level. This is where we assign the resources and also assign equipment or telemedicine equipment, e-health equipment and resources to put them to use in the field. This is a toolkit for public health managers by PAT and WHO in 2013. Is available online. Most times you see that vendors comes to most of our hospitals, either the tertiary, the secondary, or the primary, but most of the recipients of these tools and resources, because they don't have their own roadmaps for e-health, they don't have it for health informatics, you find out that sometimes we are at the mercy of these vendors, of these platforms and technology. So number one, it is important that before you deploy, your outcomes must be well defined, as we have seen in the components of the roadmap. You must have a well-defined outcome. That is, what changes with this health informatics, e-health system bring and benefit to your establishment, your institution? What should be the scope? Is this going to be in phases? And how will you measure the success? Very important. And there must always be a team where the skills levels are known. If you have to hire an external resource in terms of skills is very important. And then you require to bring everybody so that you can meet the specific outcome. You must define what your system needs to do. It's very important. It's not just because of the technology, it's for the people. It's never about the technology. It's improving that system for equitable and affordable access to universal access to health, improving the well-being of all. So you must define your requirement for the system. And that means you must know what needs for e-health and informatics that is required for you to roadmap successfully. And then how do we get the right solution? In finding the right solution, you should buy. That's when you want to know, are we going to buy? Are we going to build our own system? All of this will depend on your outcomes, your team, and then what exactly are your needs for e-health and digital health. Of course, you have to select the vendor. So make sure that you get the best vendor based on your assessment of your e-health environment. And then it's important that at your implementation, you have the operating costs, and not as well, you have the cost to pilot, the cost to scale, and the cost to maintain. It is important at the design stage that we design to scale. And very importantly, number 7, have an implementation plan so that if anything goes, because you have done your risk assessment in developing your roadmap, you know what changes to take, and then apply the principle of flexibility to ensure that you can move that project forward. And lastly, you must be able to manage the project risk and understand it. Some things can go wrong. And we have seen in most of the projects in Nigeria, a lot of things have gone wrong. There was this popular project that came during the President Obasanjo administration and was sponsored by the National Space Research and Development Agency, NASDA. We have 7 federal medical centers connected to 2 tertiary hospitals. One is UCH and the other ABU Teaching Hospital, Ahmadu Bello University. Today, that project is not running, it's not functional. During the COVID, we saw the bus came up being revived. So if all of these are put into place, it must not be about the project. E-health needs to be deployed as an intervention, and you must have a programmatic backup. That way, you can't sustain it from your piloting and then from phase 1 to phase 2, phase 3, because there must be a long-term strategic plan for it. That's how well it can be deployed. And quickly, please also note there are markets that are determined by this enabling environment. Some are fully regulated, some are guided, some are free market. Ours is a regulated market. It's government that drives development and adoption. And that is why you have seen that we are perhaps a bit lagging behind in some of our projects. Okay, it's important that you understand the environment where you are, so that the implication for that is that most of the visions at the national level, at the subnational level, or FAST level will be coming from the authorities. And this is how your roadmap will look eventually when you start the process. So either you are developing your new roadmap, strategic focus, or you are reviewing it. You have this framework. It serves as a guide, your activities, the resources that you need at this stage, the timeline, the budget, who are the responsible persons, your stakeholders, and then how do you measure progress over time? Well, as I begin to round up, there are challenges to road mapping as well as deploying e-health and informatics, not just in Nigeria, but in the developing countries and particularly sub-Saharan Africa. Self-limiting cultural beliefs in the past years, which I believe COVID-19 has become a very strong driving force, and that there's a shift both in the cultural beliefs of the consumer of health services as well as that of the healthcare provider, who never thought care or health services could be provided using this technology. Lack of policy, though we have a draft national health policy, and hopefully by May, June, it should be finalized. We don't have specific legislation on e-health and informatics, but there are groups of legislations that are important. The National Cybercrime Act of 2020, the National Data Protection Regulation of 2019, the National Health Act 2014, and quite a host, the National Industrial Standard for Health Informatics. All of that contributes to an enabling environment and places Nigeria at the building and develop stage, which is stage 2 of an enabling environment for e-health. We also have health insurance limitations when you talk about financings and how do you also return on investment when you make this investment. The National Social Health Insurance Scheme at this stage, until the new bill is out, does not provide for payment of healthcare providers who provide services over this technology. So it's very important to have this when we are road mapping and resourcing for e-health as well as health informatics. Of course, infrastructural deficit is also there in terms of reliable internet. My internet has been unstable quite some time in the course of this presentation. In conclusion, technology advances, whether you take it as e-health, digital health, health informatics, telemedicine, telecare, telehealth, telemonitoring, they all have proven to possess huge potentials to strengthen health services across Africa and particularly Nigeria. But road mapping digital health in an enabled environment is a prerequisite to tap into the potentials it brings to healthcare. Thank you very much, sir. Thank you, moderator, and thank you, co-panelists. I've come to the end of my presentation.
All right. We appreciate you very much. Thank you very much, Dr. Adebola. That was quite a very, very rich lecture. I see your down-to-earth approach to issues, the expert knowledge, but with very good clarity on delivery. We appreciate you so much.
Thank you, sir.
We're going into the panel discussion right away. Other panelists, like we indicated earlier, are joining. We have okay, so we have on the panel Dr. Kingsley Ukauha. He's of the Department of Computer Science, University of Benin. Dr. Kingsley Ukauha holds a PhD in computer science. He specializes in software engineering, ICT applications, and internet-related research. He's an associate professor of computer science and deputy director, ICT Center for Distance Learning, University of Benin. He has keen interest in prospects and challenges of telemedicine in Nigeria. He is a senior member of the Institute of Electrical and Electronic Engineering, member Association of Computing Machinery, and fellow African Scientific Institute. Dr. Kingsley has been actively involved with the plans for MEHID-Africa 2021, which demonstrates his keen interest. Right, Dr. Kingsley Okauha, you need to unmute yourself, please.
Good afternoon, Prof, and good afternoon, everybody.
Thank you very much.
Oga Olajide Adebola, thanks so much for your insightful presentation. I so much enjoyed it.
Sorry, thank you. May I ask, is somebody representing Professor Ogbaifun?
I won't be aware of that. I think he was aware.
No, I'm asking, sorry,
No,
I'm
sir.
asking all attendees, everybody, not you. He told me that he was requesting someone to represent him. So I wanted to know if there was anybody among the attendees representing Professor David Ogbaifun. Okay, if there is such a person, please let us know so that we can quickly recognize you. All right, thank you very much indeed. Dr. Olajide Adebola, you've done a very incisive work on your topic, and today we have the opportunity to look at it in a very practical sense. You have been on the road for a very long time, so you must have a map for your own movement on this long journey of e-health, an unending journey. So you should be able to tell us how long the road is, since you know the map itself. Road mapping is applicable at international, national, state, so some other subnational levels. The whole idea is to ensure that the deployment of e-health and health informatics is efficient, purposeful, systematic, and targeted at the most urgent and most relevant things at the right time. And that Dr. Olajide has said loud and clear. May I have your insights, Dr. Okauha, about Dr. Adebola's presentation?
Thank you so much, Prof. I think his presentation, like I said, is quite insightful. He just talked from the practitioner's point of view and from the point of view of an expert. For those of us that are in charge of implementation and designing the infrastructure that will help drive e-health and telemedicine, we are quite concerned about an aspect that is mostly overlooked, and that is the gathering of requirements from the vital stakeholders so that we can be able to carry them along. Requirement means what do each of these stakeholders need so that we can put it in place. And then when we are now designing an appropriate e-health policy or model for Nigeria that will work, we must take into cognizance the view of the individual stakeholders. Because what works for China and what works for the United States will not work for Nigeria because we have our own peculiarities. If you check rural, urban situation here in Nigeria, that is not how it appears in Japan or US. And if you also check some of the things that are put in place like telecommunication network, light, government policies, they are not also the same as what we have outside. So my concern is, are we really carrying the stakeholders along? Because one of the parties there the doctors. Maybe they have a body called the Nigerian Medical Association. We are talking of implementing e-health. Are they being carried along? Because each time the doctors go on strike, you see the hospitals being grounded. But we have e-health and telemedicine infrastructures in place. It could also stand in the gap for such health practitioners and make so many of them not to be fully overburdened with work. So my question or concern now is all the requirements we need to get from the different stakeholders. Are we really getting them? I think that is my concern, and that is an area I'm trying to key in terms of research. Because if we can get these requirements, then we now know what design strategies will work best for Nigeria. And once it works best, Nigeria is a highly potential market for e-health and telemedicine. Any investor that puts his money there, believe me, will be able to earn high returns in no distant time. Because right now we have the highest mobile penetration rate in Africa and the highest tele density in the world. So when we take advantage of those advantages, of those structures, we could make a lot of money and also enhance a lot of development in our policy.
Right, great. So I could see Dr. Lajide Adebola apparently absorbed by the comments he made, as if he was going to add his voice to it. So now you have the floor. You want to comment on what he said?
Thank you very much, Professor Adeleye. Let me publicly and internationally acknowledge your mentorship and also support in the past years of the journey of the road, with not a very clear map as far back as 2004, 2005, but vision brought us here where we are. For the benefits of the participants, people have asked me, how did I get involved in e-health, health informatics, without studying it at either undergraduate level or not in medicine. It was a vision as a second-year medical student. After being posted to a village in Kwara State, I finished my medical degree at the University of Ilorin, Kwara State. We have this community-based experience services. It's been organized by the Department of Community Medicine and the Public Health. And firsthand, you could see challenges in the community. And you were looking like from a royal palace when you look at access to and equality to health services. So from there, I began to ponder how could you solve the problem of access. As far back as 1995, 96. And so I knew if I finished med school, I'll be outside of the clinical box and then looking out to solve some of these problems. At graduation in 1999, we had the Millennium Bug, and it became very evident that computer and computer science, information technology could actually be a tool to solve this problem. So for me, it's a vision, and I've journeyed that far because I have people like Professor Omokai Adeleye who provide supports and word of advice each time we consult them. Thank you very much, because you never know that you have played that role. The words of encouragement, because there's no career path for any professional who is in digital health, e-health, health informatics in Nigeria, not even in the MDC and KDA itself or the government. And so it has been strategic thinking and road mapping personally to have pursued a career in this path. And that has brought me this far today to whatever opportunities I've seen to serve the country and the capacity which I'm serving at the moment. So in terms of gathering requirements, whether at the project level or at the national enabling environment, Dr. Kawa Kingsley has rightly put it. Our challenges of our political leaders, the challenges from our political leaders, administrators at all levels, that they have a very short time span in offices, and they really want to see projects deployed. So oftentimes, even when a process to manage the resource allocations for digital health is in place. Because of the eagerness to get this project or this vision to reality, the steps of requirement gathering is usually missed. That is one. That is what I've observed so far. And so by the time the project is deployed, it's usually off the shelf from a vendor, a closed proprietary system. And once it's commissioned, that is the end of the project. It talks about stakeholders engagement. It's very important that we engage stakeholders, because one of the risks is the healthcare providers themselves refusing to use these tools. We have seen that in some of our tertiary health hospitals, where the executives and the management were visionary enough to deploy these technologies, and the healthcare providers are not using it. These are multi-million naira projects. And that leads us into another aspect, which is the need to now start having curriculums, to start training the younger generations of professionals in ICT, in health sciences, such that education can stimulate demand for the use of these systems in the future. Because the culture of providing care, the culture of training these health sciences students does not emphasize the need for this tool yet. They are not using this tool while training. And so when they get to positions of executives and decision-making, you see that we have a kind of a reinventing the wheel process. So this has contributed to adoption, particularly in our environment. Not that healthcare providers don't use this technology, because e-health is essentially a generic adaptation of e-commerce. So you can do your banking, you can do your shopping on Shopify, you can go to Taxify, you do all that at home. It's the same technology arrangement when it comes to the health sector. But because in bringing them up, in training them to become professionals, no one has introduced this subject in details to them. And that is where I see MEHID-Africa really coming very strong to serve as a resource base, not just for research, but to inform curriculums of trainings for health sciences and ICT students. And that begins to bridge the gap between the different stakeholders that will be involved in deploying electronic health. At the national level, Nigeria is very vast, very, very vast. And so time and chance, for instance, if you follow the National EHED Toolkit, Strategic Toolkit, the publication of WHO and ITU 2012, sometimes the development of a national EHED vision requires between 8 to 12 months. Sometimes not many stakeholders will have the time frame, will be able to wait for that process. Also, reaching out to critical communities. And for instance, I know that about 150 stakeholders were involved in the current National Health ICT Strategic Framework that we're evaluating at this health term. And they come from the NMA, the nursings, the associations of healthcare providers, their regulatory bodies. So that engagement must go beyond when we have decided to initiate projects or programs. We must look at the ongoing professionals. What are the continuous professional development requirements? What are the short courses or average courses that needs to come in now, such that they can embrace this concept, understand how to successfully deploy it. Each can roadmap for EHED informatics, and then we begin to see the potentials of these technologies tapped into.
Yeah, thank you very, very, very much for bringing us into further depth. And I must appreciate you for your very kind words. At a point, I was almost asking, I hope you got the right name. Did I do all those things you claim that I did? Thank you very much. I appreciate you. We might as well, in fact, switch the names and say that, well, you provide the platform to find expression. And I must say here that nobody can talk about e-health and telemedicine in Nigeria without talking about Dr. Lajide Adebola. It's not about praise singing, it's a matter of fact. He wrote to different teaching hospitals, and we're wondering, who is this person who's so bold to be moving different institutions across the country? And the first day I met him, I wondered, such a young man mobilizing the whole of Nigeria. Then I knew that, yes, we were in for a good time, because you needed the zeal, the power, the intelligence, the skills of the youth to be able to move us that way. He's getting old himself now, and I know that he's making impact on many young doctors across Nigeria and beyond. Good enough, many consultants across the country now practice e-health and telemedicine based on the initiatives that he introduced. I must commend you very, very, very much. I remember the days you worked with one of our keynote speakers, Professor Temitope Alonge. It was through you I even got to know him, and I must really, really commend you for keeping the fire burning. So I encourage every one of us to follow the kind of lead that Dr. Adebola is giving to Nigeria. That's where we'll be able to have proper road mapping, not only at national and sub-national levels, but also at institutional levels. Yeah, so in a moment, we shall be listening to attendees. We shall be getting their comments and questions. But we want to look at examples of how road mapping has helped health systems. We do not have very many to look at, but at least one or two may exist. In your consulting job, Dr. Adebola, have you come across any institution doing proper road mapping? How did they go about it? Did you have to help an institution to develop capacity for road mapping? Did you have to work with any national or sub-national body in order to deploy road mapping, in order to use road mapping in deployment of e-health and health informatics?
Thank you very much, my mentor. And then it's good to see you set the stage again at this very young age of yours. I believe everyone participating will readily take these steps and follow those who have created the paths, and together we all get the benefits of using this technology. Thank you for those kind words again, sir. I must say that I've been privileged to have served in several capacities, both at the national and the international level, excuse me, mostly as a technical person. I would like to speak of my engagement at the Universal Service Provision Fund of the Nigerian Communications Commission. That was between 2014 and 2015. I served as the e-head advisor to the Universal Service Provision Fund. As a matter of fact, I initiated that the Nigerian Communications Commissions through the USPF should actually serve as sponsors and provide funds for digital health initiatives, because a certain percentage of every calls that we make, of every IT equipment that comes into Nigeria, telecommunications, goes into that fund for some kind of rural telephony, rural technology center. So why can't such a body already established? Because the challenge when we started way back 2005 then, during the President Obasanjo administration, was the fact that how do we source funding for these technologies? And knowing very well that in the health system, apart from these challenges, resources are very meager. So as an advisor, we did road mapping to chart a course for what the Universal Service Provision Fund should be doing in the e-health space in Nigeria. Yes, they have the fund, but what sort of digital tools is required? So to do that, we as part of my role as advisor to the secretary, then executive secretary of the USPF, we set up an e-health team within the USPF organization itself, so that we can also institutionalize e-health as part of their project unit, within their project unit. Of course, individual skill sets were mobilized from both NCC and myself, coming from the health and the e-health background, to complement that particular unit. So that was the first step. And the next thing was engagement of stakeholders. And stakeholders were engaged at different stages. So what we did then was to scan the environment. So we did a rapid assessment of the national e-health environments at the secondary care level, and 107 secondary care facilities across Nigeria in each of the 6 geopolitical zones and FCT were mapped for that particular assessment, to look at, based on those 7 components, leadership and governance, in terms of any strategy or investment, look at what services and applications are deployed. As at 2013, the then Lagos State Administration, that must be under the current Minister of Works and Housing now, Raji Fashola, they had already deployed electronic medical records in 11 general hospitals in Lagos State then, as at 2013. And we also find out in Cross River states, there were some deployments of electronic medical records. Overall, when we finish the assessment, we find out the risks and the challenges to deploying any e-health projects in those facilities. We also find out that there were also systems from vertical programs, like tuberculosis control program, the national program, malaria eradication program, from HIV NACA programs, which comes with donor funding to support some of these national intervention programs in the health space. So some of these systems are also deployed as part of their care for HIV. And so you can have in a general hospital multiple patient level data management systems, and then this sort of multiple systems are not talking to each other. So if I go in for TB services, my record is collected on a particular electronic medical record. And if I use the general Medicare services in the hospital and other services, I have records in another system. Those were some of the findings from the assessment. We also realized not many have been trained in health informatics or electronic health among the workforce. So we realized there were low skills and knowledge among the workforce in these 100+ secondary care facilities in the country. And part of the finding, again, was the fact that most of them does not have, even in Lagos State, who seems to have the most advanced stage of development, deployment of here, then in terms of EMRs in about 9 to 10 general hospitals in Lagos State, did not have any organized team to oversight, to monitor, to maintain these projects. So the tools were just deployed, and then training were just done. And so we also found out that in some of these facilities, they don't even have hardwares, okay? They don't have devices at all for their operations. Talk less of now exchanging data beyond where it is created. So all of these were the summary of this finding. And this helps a lot in terms of knowing advising what USPF should do, how they should go about it. So we were able to define what should be the outcome for USPF. And what we advise is that we cannot go to the primary care level, one, because for USPF, their mandate is to provide internet-enabled services. So the services must come with the provision of broadband. So there's broadband first, but we need the broadband for these e-health services to be delivered in the communities. Of course, USPF cannot go beyond the reach where vendors and the national carriers like Globalcom, Nitel, Airtel have deployed their fiber optics, or where there is a need for terrestrial telecommunication system to be deployed. So that also limits the extent at which e-health solutions can be deployed. So we came to a consensus that deployment should take place at the capital cities. One, because there will be access to internet and broadband in those facilities. Also, the need to protect. We also find out that in some of the places in those secondary care facilities where tablets were being given in the time past, computer desktops were given, it has been vandalized. Some have been carted away. So for security reasons and for monitoring, this informed also the choice of devices and how the USPF EHED project was designed. So very importantly, the requirement gathering, the user requirement analysis, the stakeholders. So when we've finalized the assessment report, we called the stakeholders meeting. So we invited everybody for purpose of validation. We shared that report with the stakeholders that were visited their hospitals, and they all came for a meeting in Abuja and then look at the findings of the report, and it was validated. So that formed the basis to say that for now, if USPF will be intervening in the EHED space, it can only provide digitizations of hospitals, and which cannot take place at the primary healthcare level, because USPF is supposed to provide those internet-enabled services at the very rural communities in Nigeria. And so this can only take place at the secondary care level. And most of the functional secondary care levels that will be close to any of these mobile internet services or ISPs are likely to be in the state capitals. So this informs the requirement for the choice of locations where the deployments will take place. And it is interesting enough to see that since 2014-15, after my adversary termed out, USPF has been carrying out over the years the deployments of electronic medical records at secondary care facilities in each of the geopolitical zones across the country based on the work we did then. I've not been part of the auditing of those projects. I've not evaluated them, but I also know there are challenges because as at that time, the enabling environment is still at the early adoption and experimenting stage. We have ICT infrastructures, but we never had this strategy document. We never had the policy, which is in its draft stage. We never had standards for the country, okay? And then we have issues of interoperability, which is still there today. We never had a national EHED architecture design, its features and components. And we have not really, even up to now, defined the interoperability layer to have a national health exchange information that will allow disparate systems to be able to communicate together and link to the National Health Management Information System, which is DHIS2. So all of these are still there, but then, so this guided the USPF to now say, okay, we have the funds, we can only deploy in secondary care levels because there will be some sort of deployment. And then I ensure that training is very important. In fact, when I advise organizations, let your projects, 40% of your budget be dedicated to training, because you need to build the capacity of the users over and over again. And the reason why I advise that dedicate that much for capacity building is not just in the platform deployed or how to use those tools, but also in the rudimentaries and fundamentals of health informatics and electronic health, because that will help their understanding a bit, the relationship or the marriage or the coming together of both the ICT and the health sectors, and then can also help stimulate the continuous use of those systems. So I believe over the years, this is almost 7 years, 6 to 5 years now, they have continued in providing some secondary care facilities with electronic medical records. I know some of those will still require standardization because we just adopted standards in 2019. Now we require a bit of re-engineering to meet national standards, because according to the National Health Act 2014, health software too requires a certificate of standard. And then because of the safety, because errors could also occur, Dr. Kingsley Ikwa will bear me witness to that. Even when we have prescriptions electronically, if we are not able to flag drug allergies on our EMRs, if there are no decision support systems, we cannot uniquely identify the patients on such systems. So we still have some of these little challenges here and there in the environment, but that's not to say that we should not go to the field. I keep saying something, e-health usually exists in the abstract, in its concept, but without going to the field to deploy, you will never learn any lessons. And then the truth is that we will not improve on whatever we have, and then we can just be stuck there, keep singing the praises of the benefits of this technology. So that was our roadmap at USPF. And the USPF moved to the next stage of selecting vendors, because the government institutions and their projects must go through the National Bureau of Public Enterprises and bidding. And so vendors who meet the pre-qualifications bidded, and those who were successful at the bids implement this project based on the assessment that we made.
That was very, very, very great. That was another lecture on its own, I must say, because that threw us into very hands-on experience on at a national level. And I'm beginning to appreciate how that road mapping is applied at national level. And I hope that persons from other backgrounds, even beyond Nigeria, are appreciating what is going on here. That unless you have a national roadmap, you may be wasting resources. So from what Dr. Olajide Adebola is telling us now, things may not be as they ought to be, but there appears to be sufficient grounds on which to say some work was done, scanning was done of the environment to appreciate not only the needs, but the way processes are going on in order to adapt interventions appropriately. So thank you very, very much, Dr. Adebola. Dr. Kingsley Ukauha, you must have some insights on this. Can we hear you? Can we hear from you?
I think I am so much enjoying his lecture so much, everything he has been saying, because he has a lot of experience. And I begin to wonder, why have such persons been hidden away from us for so long? He is the professional, that is the practitioner. We are the people who are in charge of designing the infrastructure and the backbone. So we needed to have worked together, collaborate, so that we'll be able to map our strategy on how to deploy better e-health solutions to the country. Like I mentioned before, road mapping is very good because it will give us a guide. It will make us to stay focused. And at the end of the day, it will also allow us to have some established rules and regulations we need to follow in order to get to where we want to go to. Requirement analysis is still a far cry from what I'm seeing now. Because what we have in Nigeria is we rarely do design these solutions on our own here. We prefer getting them from outside, ready-made, and apply them here. And like I've been saying, what works for India, China, and Japan, because of their own peculiarity, may not work well for Nigeria. So when we are bringing such solutions to Nigeria, we need to look at our own individual peculiarities, tailor them, adapt them to our environment, and they will work better. Take, for instance, the Mose phone. The young man came from Nigeria, went outside, got all the technology, and came here and adapted a phone that could work better for Nigeria. Same thing with ITEL and Techno. And then we also saw Inosim Motors, the same Nigeria brand. So our e-health solution, if we're able to have a good road mapping, which is okay, like we already have the National Health Act, which should serve as a guide, let all the practitioners come together in terms of multidisciplinary collaboration and see how we can get local solutions to solve our e-health problem. Dr. Adebola, thank you so much for your presentation. I still enjoy it. And I look forward to playing the recording over and over again so that whatever points I missed out during your presentation, I'll be able to at least fill them out. Thank you.
Yeah, Dr. Adebola is a resource anytime. I just love listening to him. A part of the beauty of listening to him talk is that it just doesn't seem to be to have an end. He just keeps talking. When you think a point is exhausted, it's like he has just started it. He has so much. He's a human library any day, anytime. A reference material that we can always be proud of in Nigeria. And we are happy that he's not been theoretical about it. He's practical and down to earth. He's making things happen. He's informing policy and driving practice. Thank you very much, Dr. Adebola. We're waiting for questions, for comments and reactions from the attendees. So if there are, please do not hesitate to indicate. We have not seen the sign of any yet.
Okay, Dr. Adebola, while you were mentioning your stakeholders, I noticed that you left out one important part, that is the health workers. Was that an omission? Health workers like doctors, pharmacists, nurses, health record personnel, they were not included among your stakeholders.
Please unmute yourself, Dr. Adebola.
Thank you very much. I didn't state them by the health workforce. I state them categorically where they all belong. So they are all constituted laborers. They are part of the labor movement, those that provide the services. So you see that we also have non-governmental organizations. We have the industries, the vendors. Those are technical people like you yourself who designed some of these platforms, who have done software engineering. And then we have government on its own as a stakeholder. And then most importantly, the most important out of those 7 categories is the patient, the consumer of the service. Oftentimes, they are not taken into consideration to know whether, okay, by the next 3 months, University of Benin Teaching Hospital, pathology services, mental health services, as well as dermatology services will be done remotely now. We now have outstations or mobile outreaches or telemedicine kiosks, so and so communities. You can go there at so dates, and then you get your test done there by our registrar or senior reg, and then the consultants can review some of the slides, because this doesn't require read time and consuming a lot of bandwidth. That in itself is very important that the patients know, and also know how these informations will be shared, how they will be stored. That takes us to the governance aspect of health informatics or health information governance. So how would they be disclosed? Who are to share it? What are the ethics? And every stakeholder must know their role ab initio. That helps ownership. So most importantly, this can be done without the workforce. That's why the workforce is very critical. Under those categorization from the ISO, those includes, they are under labor. So the NMA, the nursing associations, and all of them, They are all part of the stakeholders. It's very important.
Okay, thank you very much. Thank you. There is a question here from Elowosa of Webe. Elowosa is asking, is it possible for regulatory bodies to extend e-health training to students still in medical schools? I believe it will move e-health steps further towards its goal. Very, very important comment. And I must say here that we are happy that the current dean of the School of Medicine, University of Benin, is a part of the supporters, is one of the supporters of this program, and is happy to admit that as a part of review of the curriculum of the medical school. That, of course, goes beyond just medicine. It cuts across all disciplines. You'll notice that the issue featured in the Vice Chancellor's opening address. We want to translate that into real practice. In fact, we should be talking about this at the level of NUC and at the level of other professional bodies such as the Medical and Dental Council of Nigeria in curriculum review for the different professional curricula. So Elowosa of Webe, thank you, thank you, thank you. I'll be happy to have you follow up on this. You can reach me later on if you are in Benin, if you have access to, if you're University of Benin or in the environment, please reach me so that we can work together on this. I want to keep track, I want you to keep track of this and own a process of advocacy, which you are indeed doing here. Thank you very much. All right, so I think at this point, okay, we have one question. This is from Osaibovo Ehigeba. How far has the standardization of healthcare software gone? We have many vendors churning out applications. Sooner or later, we will need this database to be unified, so to speak, or interoperable. I think Dr. Adebola spoke to this in his presentation. Software vendors, the issue of standardization of software in Nigeria. And we have another question, you might as well take this along. Alongside, what will be the cost implication of e-health deployment to patients? That's a very big or very wide issue. I can immediately introduce the answer to the second one. Like I said during the introduction, Dr. Adebola is passionate about mHealth. One reason is that it enables easy access to e-health services by individual persons who need healthcare. So just to remind us, the first question, how far has standardization of healthcare software gone in Nigeria? Vendors are all over the place. We need a database, we need interoperability. You have the floor, sir.
Thank you very much, Professor. Thank you, Osaigo, for for your questions. Innovations will never wait for standardization. They will be in their legions. If you go to health and wellness hubs, it's even difficult to regulate that environment because every day there's all kinds of tracking devices that are being developed. But when it comes to service delivery, services and applications, there are standards already out there. And what we have done for Nigeria in the last 2 years is to bring stakeholders together. It's an ongoing, and we'll be glad to have, we have participants from a research group, which represent academia from the Ladoke Akintola University, a Center for Mobile Computing and MEHID Telemedicine Health Research Unit led by Professor Justice Emoy Baffa. And then we can also have MEHID-Africa participates also in the standardization process. Now, the standard exists. Ade Bessin et al. In 2013, in a scope of standards in Africa, sub-Saharan Africa, find out that only one country was participating in this standardization process, and that was South Africa. And I got to know that when I discovered their paper in 2015, and after my postgraduate, decided to start working on standardization. So there are standards now, both for data exchange as well as for interoperability. What we have not done yet is for the Ministry of Health to develop guidelines and start training for the vendors who turn up these quite innovative applications to ensure that their standards, their products meets safety requirements as well as secure exchange of personal health information over these applications. So Nigeria has standards. But for interoperability, we have not also adopted, though we have recommended it, to have a single national clinical terminology. That's very important for our EMR, electronic health records, to talk to one another, to interchange or exchange secure patient information over a network. Appendicitis in University of Benin Teaching Hospital must be the same definition as appendicitis at Ahmadu Bello University Teaching Hospital. So we need to have a common clinical language, diction or dictionary, and then SNOMED CT is what we have recommended to government, to the Health Records Officers Registration Board, who seems to have the mandate of the Act of Establishment for Health Record System in Nigeria. So it's very important that that those deploying should start using SNOMED CT as their terminology language. And once we have that, that also will reduce the costs of development, because now Nigeria is not a member of SNOMED CT, and therefore you'll be paying as up to $500 for the license per facility. For instance, University of Benin will pay $500. But if a country is a member, a pay member, it should be available to you at a very low administrative fee, basically for updating Nigerian membership in that group of standard development organization. Also, the Standard Organization of Nigeria has paid on behalf of Nigeria for us to be part of the TC215 Health Informatics, and that allows us to also have access to these standards. Though it's not free, they're available at SON if you need them. And I can share the list with the convener of this conference, and it can share with you so that if you know a vendor, they should start using it. Of course, when compliance comes to place, time will be given for those softwares that are out there already to re-engineer where necessary and apply these standards so that there is a certificate. And part of the plan is that there will be a portal that you can go to that will show certified health softwares in Nigeria. So if you're not using the certified product, and then so you are at the risk, and then for whatever issues that arises or incidences that could arise deploying those software. So it's important that those of us who are interested should scan the environment properly to know what Nigeria is vast, and sometimes it's difficult for information to reach the periphery. But in meetings and forums like this, we share such information. There's a work going on now for advocacy on those standards, and by the end of this month, there will be a framework by which to communicate those standards. There was a second question. I think that has been taken off. We have a national HIE, which is supposed to be the motorway for health information across Nigeria. And that national HIE infrastructure is yet to be implemented. Once it's implemented, it takes years of a different applications environment, whether it is open or closed. Once you use those standards and there's an application interface that allows data to be exchanged to other systems and enable the Federal Ministry of Health have access to population data as well as patient level data for planning at all levels. So Those are some of the works that are ongoing at the moment. We hope in the near future, we will have standardized solutions running in all our facilities across the country. I'm also aware that the Medical and Data Council of Nigeria, particularly for telemedicine, is trying to work on a sort of a policy or a guide to see how telemedicine, because COVID has made some of our service providers to use telemedicine through last year and all these years. And it's important that they are guided because of medical legal reasons. So that is also will be contributing to standardization within this space. Also, the Federal Ministry of Health is also working on the National Guide for Telemedicine itself. And I think all of this work by May should have reached its maturity, and it will be out there on the website of the Federal Ministry of Health so that we can all be guided. Kindly address concerns about patients' information and confidentiality. What is health informatics? Like I said, involving all those sciences. So it is essentially how this information is collected from the point of service, how it is stored, and how, when it's stored, who have access, how it's shared, and what use do you do to it, maybe after analysis, and what do you do with those personal health information. We now have a National Data Protection Regulation of 2019 that actually deals with data subject matters. And it also comes with a compliance, and there's penalty for data controllers, such as University of Benin Teaching Hospital, who does not handle data subjects data as outlined in that regulation. So the concerns can only be addressed by continuous enlightenment, continuous advocacy, and education of the patient's community for them to understand that their informations will be secured, will be exchanged securely. And then, of course, there's a new wave of colonization, which is data colonization now. We're in the knowledge age, and then data science is becoming a fast-growing paced field now. Most of us who did global EHEAD courses, most of the courses now are being changed to data science because of the advent of artificial intelligence, robotics, and machine learning, really smart wearable devices in the health sector. So an individual can produce such a huge amount of data from all of these wearable devices, even from your mobile phone. It tells you how much distance you have walked in a day, whether you are running, your BMI. All of these are being put together and then analyzed using some algorithms, which helps to improve the kind of devices or the kinds of programs. So most importantly, quite a lot needs to be done such that the patient community understands. And that's why anyone or establishment getting involved in health informatics projects must also be ready to carry on the patient community who access services in that establishment or that facility level, such that they become aware. And then not that you now see your health records somewhere on the social media, and then of course, you know what next to happen. So there are security socket layer, SSL, secure socket layers, and many other that ensures transcriptions of these informations as it moves across the network securely. And then because of data colonization, for data protection now, the in thing now is that health data must be stored in country. Oftentimes in the time past, we have donors come with their systems, support programs. All of these databases are stored abroad. And then they come back to us with new products, new vaccines. They take our data. So, and then we keep buying at high expensive money, informations that are coming from us, from our citizens. So the essence of data governance is very, very important. Thank you for that question, Augusto.
Thank you very much. Osigbemi Augusti is the leader of nurses in the University of Benin Teaching Hospital, and one of the leaders in Edo State, Nigeria. So he's talking from a very strong patient perspective, because it quite appreciates the cost to them, and it's going to affect nursing practice. Again, still talking about cost, I can see the answer here provided by Dr. Kingsley Okaoha. He says patients will pay part of the cost, but for effectiveness, the mobile service providers could provide low-cost internet services as part of their corporate social responsibility, while hospitals could provide access to their database at little or no cost. If done properly, the cost to be borne by patients may end up being data costs, which are getting cheaper. And I think that makes sense. It raises hope for the future for our patients. That resonates very well with what Dr. Adebola has just talked about. Thank you very much.
If I may contribute because of time, it's important that the WHO and the UN system sees digital health, electronic health, as a means of achieving universal health coverage by 2030. And so this is because the cost of technology has come down, and therefore that is why the national health insurance must have its policies such that our national carriers, okay, from the Federal Ministry of Communications and Digital Economy, must have some sort of tax rebates and incentives for them to provide cheaper broadbands for the health sector, for the hospital facilities. There's a national broadband policy and strategy in place by this administration that will enable last mile users like health facilities to have access to cheaper broadband, but we should still go far to see that, oh, if you are providing services to federal tertiary hospitals, secondary levels, you get this that will actually drive only less than 5% financing and implication of who bears the cost. Now, most of the reimbursement of payment for health services in Nigeria is out of pocket. And then we have insurance, which has a fees for service. So the question is that despite the fact that bandwidth costs is coming down over the years, which makes access to internet more readily available, despite this instability and sometimes reliability, we'll find out that the cost of services of providing health services might not change. So the cost of conducting tests at UBTH will still be the same amount, even if you were able to test yourself in a center provided by UATH as an outstation or an outreach center or a mobile station or a kiosk, okay? If the test of fasting blood sugar is ₦1, digital health here will not change because there are consumables required for those testing. I hope I'm making some sense here as to what will come down to the cost. So, but deploying this technology should not drive up the cost. That is why social insurance must be enabled by the National Act to pay for these services. And that takes off the burden from those who are not covered financially, and then it is being paid for in some sort of ways to purchase services through telemedicine. Initially, it was thought that it would drive up the cost, but now the cost will be cheaper because a doctor will want to collect his consultation fee for his practice, which is not fixed depending whether it's private or public. So the technology deployed will not change that. We should bear that in mind. Okay, the only thing is that we still need more studies into the cost effectiveness, cost benefits of this technology. That's why we need to all go into the field, and that can inform pricing mechanisms and what works best for us in terms of cost. The patients will bear some costs, the vendors will bear some costs, and the service provider will probably bear some costs, but all have cost savings at the end of the day, which is to improve services delivered.
Great, thank you very, very much. These are very important perspectives that you have brought in here. There's often the fear that it will drive up costs, but what we must also remember that technology sometimes works in a manner as to allow for more usage. A large number of persons can begin to use, which can then mean that the burden of deriving profit from just a few service users can be spread over a larger number of users, which then drives down the cost. I think Dr. Kauha will give us his closing remarks as we bring this symposium to an end. Dr. Kauha, can we hear your last words, please?
Thank you so much, my prof, and thank you, Dr. Adebola. I think it is not just gloom. There is still some optimism in the area of e-health and telemedicine, in the sense that when you look at everything holistically, you start having the fear that cost may not be driven down. But if you look at the services being provided, maybe piecemeal separately, remove them, detach them, and provide them, it may drive down cost in the long run, like teleconsulting, telemonitoring, telediagnosis. You don't need to see the doctor. It may bring down the cost. So as far as the patient is not seeing the doctor face-to-face, consultation fee may not be the same. And then if you think about the cost of hiring a surgeon from Japan and bringing that same surgeon to Nigeria to come and perform surgery, vis-a-vis using telesurgery method, the person is in Japan using video conferencing to direct the surgical procedure in the theater here. It may end up making that surgery to be very, very cheap, much more than when you bring the person down physically. I think if every of the stakeholders are adequately involved and carry along, each of the stakeholders will know where they come in, what services they are supposed to provide, which one is supposed not to be provided by this. When every one of us play our part in terms of effective division of labor, believe me, e-health through telemedicine will be a vital solution, and it will drive down health services very, very cheap in Nigeria. That is my remark.
Great, thank you very much. Interesting perspective. The economics of e-health will always be a major issue, and we look forward to focusing on that in future at MEHID-Africa. So that brings us to the end of this symposium. I want to thank Dr. Olajide Adebola for bringing in his wealth of experience, his unquantifiable knowledge into this conversation. Thank you for taking us on the roadmap to show us how Nigeria has gone so far as an example of how African countries can go about e-health. That we're not doing well for now in Africa does not mean we cannot do better. There is hope based on the so many factors that we have mentioned. The market is big, the need is big, and that means that there is opportunity for investment, because this also calls for investment, as we have said again and again. Thank you very much, Dr. Kauha, for your contributions also. Thank you for the insights you have brought in. Thank you participants too for your comments, your questions. Thank you for being a part of this robust discussion. We do hope we'll be able to translate all this into value with time. We appreciate you. Tomorrow, we shall be continuing this conference. We'll be dealing mostly with abstracts. Abstracts are going to cover the ones submitted by people who want to present their abstracts. We're going to have scientists talking, and we're going to have experts critiquing their presentations. These abstracts are partly based on research and some are commentaries. No matter what they are, we have about 10 of them that will help us to engage, that will lead us into serious engagements. And I want to appeal to all our resource persons so far, including Dr. Olajide Adebola, to please take out time, come in, come out, and be a part of our discussion tomorrow on the submissions by researchers, by students, and others who want to make impact on e-health and health informatics, who want to make progress. Thank you very much. We shall share the more information on the program for tomorrow. I think our participants, our attendees all over already have the detailed program outline. So please go back to it to just remind yourself of what we're going to do. The abstracts are constructed around the different sub-themes. Some cut across multiple sub-themes, and some deal with this theme itself. So it promises to be a rich day tomorrow. All students, all lecturers, experts in ICT, e-health, you're welcome on board tomorrow. Thank you very, very, very much. Any attempt to be free to end this?
Hello. All right. Good evening. Welcome back from the plenary sessions. So we're closing for the day, and we hope you had a great time today with all the information that was shared, and we have been well enlightened and educated on issues concerning business models and road mapping for the deployment of e-health and health informatics. Hope to see you tomorrow morning. Our readings for tomorrow will be sent to our mail. Thank you very much.